the implant cost could be as low as 12,000 for a single level construct, can go up to 1,20,000 depending on the patient's affordability. But most of my target patients whom I operate want this as the cost. This is what they are ready to spend, but they want a result as though they have spent 1,20,000 rupees. So we cannot. One thing is, yeah, if they need it, we cannot deny them, and also we lose out a lot of patients if we don't do it. So that's why we thought, how about doing surgeries without using these specialized implants? Can we do the surgery using the regular implants, the cheapest possible implants, if possible? So this talk was made some time back, but right now we have one more option, cannulated reduction screws, which I got especially made for me. So this is what I work with right now. But this talk is about how we can do surgery without using a specialized implant, specialized screws for minimal access surgery. So the technique is the surgical part of it. The technique part of it is same, paraspinal approach. Usually, most of them, some of my surgeries could be for fractures and all, but most of the surgeries are fusions. So I do decompression using a tubular retractor or Ramani retractor in early days. Now I have a tubular retractor, so all the decompressions are done in a tubular retractor. And screws are passed percutaneously under C-arm using regular orthopedic instruments. That point of time, I didn't have any of the specialized instruments. Nobody was making in India, so I had to start doing it using regular orthopedic implants, not spine implants. So earlier days, I used to use non-cannulated regular or reduction screws. Nowadays, I have cannulated reduction screws available, which makes the job a little bit easier. So the technique is, I'm sure all of you know, initially we would put the Jamshedi needle into the pedicles. I'm not going into the technique of how to do it. I'm sure most of you are aware. So once we put the Jamshedi needle, I would put a guide wire, and at that point of time, I didn't have a cannulated drill bit or cannulated tabs for the spinal system. So I started using a drill of the 6.5 screw system, which we normally use, cancellated screw system. So I would drill initially with the drill, followed by the tab of the same system. And once it was done, when a screw track was established, then I would use a simple regular reduction screws, non-cannulated. The guide wire would be removed. Usually you can just put your finger along the guide wire, and you can make sure you can feel the hole there, and you would gently guide the screw to the hole, and you could usually accomplish it quite easily. It was not a big deal that it was not a big difficulty. On the non-decompression side, decompression side, it used to be issue because the cavity would be more, so to getting into the hole would be slightly more difficult. It would slightly take more number of exposures on C-arm, but it could be done. So once you put the screws, usually the reduction screws, the flanges are high, so usually this is in obese patient, so it's not visible. If it is a thinly built patient, the flanges actually jet out of the screw, jet out of the skin level, so it's easy to pass the screw. Otherwise, normally in the imported system or dedicated system, you have a tunneling system, self-guiding system and all. Here we don't have all those things, so it has to be visibly done. But since the flanges are already easily seen, you could easily use a rod just to tunnel it into in between the screws, and then put the top screws. It was very easy. But the one problem was to maintain once you have curved the rod, it would be difficult to maintain in that position. Once you tighten the screws, the rod would rotate. Because the space available is very less, we couldn't use a very heavy rod holders. So if you use a thinner rod holders, it would not hold, and the rods would rotate as you tighten. So we came around the way by using a hexagonal tipped rods. So these come with a very small thin hexagonal holders. So once we curve it and put it, it won't rotate. So you can use it without having a problem of rods mal-rotating. So some example, grade 1 degenerative listhesis, patient decompression done. This is how, I'm sure everybody knows about the technique. If somebody doesn't know the technique, it is jump sheet needle usually is passed percutaneously. Your entry point should be around 1 o'clock region on the right side, as you can see from here, and 11 o'clock on this side. And depending on the amount of lordosis, your entry point might vary and the angle may vary. But ultimately, when you punch into a jump sheet needle, you stop it when the needle touches the medial pedicular line, and then you take a lateral view. At that point of time, either you should have crossed the pedicle on the lateral view. Pretty much same as how you would do it in a transforaminal this thing. Never go beyond the medial pedicular line unless on the lateral view you already cross the pedicle. So once you do that, then you put the guide wire and screw insertion. So this is how it is seen once these screws are put inside. This patient is, as you can see, is an obese patient, so it is all buried inside. But otherwise, if the thin patient, it is easily visualized. You can easily put the screws inside it, and this is the the incision. I usually use a 22 mm tubular retract for decompression, and this 22 mm incision is enough for passing 2 screws. There is only one incision for passing 2 screws. So this is how the end result would look like. You can see these are regular reduction screws. This is a case of, again, a 2-level fusion for 2-level listhesis. Again, a 3-level fusion. So irrespective of the number of levels, you can use it. So if you can imagine, if I use a imported implant or a dedicated Indian implants also, the cost would be very, very high. I mean, probably the cost of implant would be equivalent to the total surgical procedure charges which I charge now. So also the advantage is, you can see the incision is again very small. One small incision you can put 2 screws. Because we are not using a bulky jigs or anything, so the advantage is your incision and dissection becomes less than the regular dedicated systems. So it can be easily done. So cost should not be a big issue if you're decided, especially now from discectomies, you are going on to fusions, minimally invasive fusions in the form of transforaminal fusion or interlaminar fusion. So whenever you put the screws are the limiting factor in your practice. So if you can start doing this nowadays, you can get your manufacturer. If you're using one regular manufacturer, you can ask them to get a cannulated reduction screws. Usually they don't make it because they want to push their minimally invasive system. They want you to buy their expensive screws, though usually they don't make it. But if you insist, they can make a cannulated reduction screws. That will make your job easy. That usually for me works out to almost 60% cheaper than the dedicated system. So 40% is the cost of the implant right now. Or if the patient is really poor, cannot afford, I still continue to use regular reduction screws, non-cannulated. Or even if the patient is very thin, I don't even use reduction screws. I use same technique, regular screws. There are certain disadvantages. As I told you, malrotation of the rod, because initial days I could not hold the rod. So I told you how to get over with it. If the ends are hexagonal, you can always fix it so that it doesn't rotate. Also, inaccurate sizing of the rod, because when you see from the top, all the screws are crowded. So once you tighten them, they open up. So initially it used to be a problem that the rod size would be small or big, but now we usually check it on CM before we do the final tightening and adjust accordingly. One disadvantage what somebody else pointed out is that we cannot compress the screws when we use this technique. So whether that would lead to higher incidence of cages backing out. But I checked for evidence. There is no this thing to say that the screw, the back cage is more in if you don't compress it. And so far, in so many years, so many hundreds of cases I've done, I've not had a single case of cage backing out. But theoretically, yes, this is a drawback that you cannot compress the screws. If you want to compress the screws, you need to use the regular compressors, then your incision and everything becomes bigger. So this is the only theoretical disadvantage which I think is there. Anyway, today case we are doing the same technique. I don't know if that will be live telecasted. If that is there, then you can see it. Thank you.
Thank you, Harsha. Any questions?
From your God's own country, Jeon. I got them specifically made, but now they are threatening that they will not make it more. They want me to use their system, which costs about 45,000 for 4 screws. Now I'm getting it for 22,000. But then I said I'll ask somebody else to make it.
I think what Harsha told was exactly correct. As far as the reduction screws are concerned, now we do have cannulated screws if they are, even with a simple screw, even if the patient is very poor, even without a reduction screw, probably we can do the job out. And then nowadays getting into the putting the screws is not that difficult. It's with a very small incision, what he told, we can directly go in and work it out. Absolutely no, and a freehand technique has become so popular. And we put around 30 to 34 screws in scoliosis, and absolutely no issues as far as the freehand technique is concerned. And what Harsha told is with minimal invasive, probably we'll be able to, with very small incisions like 6 inches, he was able to go to 3 levels and do it. And that is so true. And as you go on with it, he has got an experience of a very large number. So the time taken as well as the incision also gets reduced. Both of them will get simultaneously reduced.
We all think about malrotation of the rod because we want to have a good looking X-ray. In real life, in a poly screw, it doesn't matter which way the rod is facing. The alignment doesn't make a difference.
It really makes a lot of difference, especially the contouring of rods. That is the difference, because now there is a marking on every rod. You know, because there is a marking. You know where you have bent. If you want a kyphosis as well as a lordosis, you just match it. And you know, when you put the rod, you have to hold it at the tip. And at the same time, you have all reduction techniques now. Even if you have got a mounter, when you scoliosis, they do probably the curves will be at different levels. The bend will be at 4 or 5 places. And still we will be able to push it because of the mounters that we have. And also simultaneously reduction. It can really push the rod in, and it is Medtronics and all, it's highly malleable. And especially rods, you have to contour it well. If not, then your problem starts. The loading on the screw, the shearing force on the screw will be more, if at all, if you don't contour the rod. Contouring is, and you should never struggle with your knee when you're putting it, and you should never try to force the screw inside, so that you should not mount more on that. So minimal mounting and good contouring will give good results.
Sir, I think both of you are right. Sir was talking about when we do a lumbar fusion, because once we put a cage, a little bit of malrotation doesn't matter, because once you put a snugly fitting cage, it's not going to change.
Yeah.
As you said, in these cases, it's only radiological excellence. When you put up, they'll say, "Arey, something is not correct" and all. But as far as open scoliosis and all, yes, of course, contouring is very important. But once you put a cage, usually it doesn't matter, except for if you have used poly screws, it doesn't matter. But in a deformity, yes, contouring is everything.
Any more questions?
Sir, any issues with the thin patients, sir? Like you are putting the reduction screw to be projecting, right?
No, we take out we break off the flanges, right? Ultimately, it's going to behave like a normal screw. In fact, thin patient is what I pray for every time, because thin patient, the flange is jetting out. You can pass the rod in like 2 minutes, less than what you take for the jig. So once you break off the jig, it's basically a normal screw. Once you break off the flanges. Thank you.
Yeah. I invite Dr. Sunil Nadkarni, sir. Harsha, stay back. Sir, yeah.
This also, that also.
Now I invite Dr. Sunil Nadkarni, sir. Sir is one of Gore. Both are friends and colleagues, and most of them they are. Whenever we attend a conference, whenever we go to visit Dr. Gore, Dr. Sunil sir is already there. So, sir is doing amazing work. He's doing a lot of research in disc regeneration. So he has set up a lab in Valvalkar Medical College in DAY-3, where he is doing this since the past 2 to 3 years. And I don't know the entire secrets. He keeps revealing sometimes, but then you can ask him like what exactly he's doing, and he has got all the grants from the Indian government to continue the research, because this is going to be a path-breaking thing once it is ready. So, and he is the one who developed even the DAY-1 plug, where like the
Can you look?
where you can use the patient's blood on table, and you can use it for platelet-rich plasma, and that can help in healing of the disc. We do it routinely after transforaminal endoscopy, because whatever rent we create, that can be filled up with that plug. So that helps in blocking area also, and helps in regeneration also. Over to you, sir.
First of all, let me thank all the staff management of BRUNDHAVAN Hospital, JSS Medical College, and obviously the stakeholders, Tissue Foundation, Mission Spine Foundation. So, good morning. It's a little bit difficult to start early in the morning. Unfortunately, my only flight to Pune got cancelled, so I'm having to leave early. Hence, I'm having to bother you early. So, this lecture is more about myth busting. Okay, the biggest myth was discussed yesterday. If supposing I have to grab something behind this delicate screen, and there's a door in front of me, do I take down the door, move the screen and grab it, or I go from the side? That was the myth that was being discussed yesterday, okay, about whether we go straight from the back or from the side. But I won't delve into that. The first thing is degeneration in aging. There is a difference. That degeneration is a one-way street. Removed disc is a dead tissue. Symptoms are structure dependent. Structure is shown by MRI, and we believe that it is the structure, if we repair, the symptoms are going to disappear. Live repair by introduced cells. Cells are the most intelligent beings. They have sensors. They have got a full software in the form of DNA. They express the right proteins. They are survivors in any situation. So cell therapy is coming to the fore, especially from cancer. And the last myth is platelet solutions are complex to administer and are industry dependent. Okay, we all have this disc, okay, and post-op MRI, we pat ourselves on the back and say, good, looks good. But if this disc becomes black, okay, and causes pain, do we have anything to offer besides screws? This disc herniation ends up in this collapse. We can imagine what happens to the foramen. Do we have any solutions to prevent this? Destandau microdiscectomy, big recurrence. Can we prevent this? So let's look briefly at what we are dealing with, the tissue we are dealing with. It has a hydrophilic gelatinous core, and this softly pushes against radially arranged collagen fibers, which are about 30 ply, and they are at 60 degrees to each other. Okay, there is a great pressure on the hydrophilic disc. When we measured it, do you know what it was? we could measure it in endoscopic discectomy, and it was almost showing 80 psi. A normal car tire we fill up with 35 psi. It's almost 2.5 times that. That is the force on the nucleus pulposus. So the annulus fibrosus is not just a haphazard collagen fibers. It's a neatly laid collagen fibers of 20 layers at 60 degrees to each other. And that is how we are all able to go through life without any problems, most of the times. Now the main thing is that the disc, nucleus pulposus, although they are chondroblasts, also secrete proteoglycans. Now proteoglycans swell up, they capture water. So this 80 psi force transmission is softly transmitted to the annulus fibrosus. This extracellular matrix turnover is maintained by the particular type of cell. Okay, so the cells in the annulus fibrosus it's like concrete. In a load-bearing structure, if there is a lot of load, they would put more steel and less cement. If there is, sort of compression expansion area, they would put more cement and less steel. So similarly, the extracellular matrix has a mix of collagen and proteoglycans. Proteoglycans are the cement and collagen is the steel. So we all know that the cell numbers, cell viability decreases. Loss of proteoglycan reduces the hydration of the disc. So what is a soft push on the annulus becomes a hard thud. If I jump, because of the lack of fluid in the nucleus pulposus, it's like a hard box on the annulus. So the annular fibers start tearing from inside, and you've got repeated episodes of back pain until there's a disc herniation. Here I would like to stress that disc tissue is the largest avascular tissue in the body. Okay, nucleus pulposus cells are very peculiar. They are trained to live in this hypoxic atmosphere. So they express a protein called HIF, which allows them to be living in hypoxic conditions. But the strange thing about nucleus pulposus is that even if you give them oxygen, they still continue to express HIF. So there is no other cell in the body which does this. Over the last decade, there have been several studies at trying to address this problem all over the world. There are several international players entering this space, and we don't want to be chasing expensive solutions, as we just had a lecture on the sextant system and the cost differential. So by chance, we were not chasing these solutions. We did not look at the problem, but by chance, after endoscopy, we felt some of the leg pain is because of the RBCs bathing the root directly, and that is what causes the irritation. So we borrowed this plug from the orthopedic surgeons. Dr. Kohli was my colleague then. And we used this plug to keep away the RBCs. Now, how do we prepare this plug? Very simple. 10 ml of blood in 5 ml each, or 20 ml of blood, 10 ml each, in a 10,000 rupee centrifuge, put on either side, spun at 3000 RPM for 10 minutes, allowed to stand for 10 minutes, and when it is opened to the theatre nurse, she picks up the clot from above. Now this is very well tested in the scientific world, because dental implant industry is very big. Because of repeated tooth infections, the mandible gets mandible is not there anymore to implant the screws. So what they do is they use PRF plug with hydroxyapatite to build up the mandible, and there are umpteen papers in the scientific literature showing its efficacy. It is better than the more expensive platelet-rich plasma. Okay, it is more like a slow-release growth factor clot. So these were one of the early cases, 2014. And when he came back for follow-up, I was surprised. I thought I had operated on the lower disc because this disc looked more hydrated than the others. And it goes on and on. So we, along with my friend Dr. Bhupesh Patel, we wrote a paper on comparing the pre-op and post-op assessment of these patients. So since then, since 2014, we have not stopped using the PRF plug following discectomies. So we believe that the DAY-1 plug costs 10 rupees. It is a genetically matched cocktail of growth factors to regenerate the disc. Okay, so it is something that is easily applicable without adding much to the cost. Why was it doing so well? We went to NCCS and looked at the cells. What was happening to the disc cells with and without PRF? And the blue is with PRF. So it was showing great proliferation. So these are the disc cells recovered from throwaway disc fragments. The disc fragments that look terrible, that look hyalinized, they look almost dead tissue. We get live cells from these disc fragments. So we have, along the way, over the last 7-8 years, there have been several eureka moments. So liquid PRF is an excellent biologically active creche. So when there's an infant, we bring it home in a creche. So liquid PRF is an excellent creche to deliver cells to the target organ. All animal tissue culture uses fetal bovine serum. So the cow fetus is, the heart is punctured, they are bled, the blood is obtained, and you make serum from it. And India imports about 10,000 liters of fetal bovine serum during COVID times, etc., for the vaccine work and all the research work. 1 liter of fetal bovine serum costs about 1 lakh of rupees. Now, we have been able to do the work quite accidentally because we ran out of fetal bovine serum over the last 4-5 years using throwaway things from the blood bank. So we are quite excited that we might be able to supplement the imported petrol with our own alcohol and reduce the import costs. Now we had to first show in the lab that these cells grown in fetal bovine serum and in our platelet solution are the same using various markers. I won't go into the details of this. The main thing, CD14 is marked because disc chondrocytes are different from articular chondrocytes. Disc chondrocytes show a high CD14 marker. The other interesting thing is there is a lot of excellent growth factors secreted by these cells when they are growing. So even if you just use the medium in which the cells are growing, they are rich in growth factors. Unfortunately, we live in a commercial world. We don't mind paying I think it is 1,25,000 for 2 ml of BMP sold by Stryker. Okay, but this is probably one of the best growth factors. खत्म होने की बात आता हूँ. खत्म होने की बात आता हूँ. So we, besides the cells, we need to. So how do we deliver this these cells? We collect blood, okay, spin it. Now there is another little trick that you might want to know. Once again, it's very cheap. You can practice it in your own clinic. If you spin it at 1000 RPM for 3 to 5 minutes, the PRF is yet to set. So you can aspirate it in a syringe. and you let it stand for 10 minutes and it will jellify. Okay, so if you want to inject, it's called IPRF. So if you want to inject this PRF, say for tennis elbow or something, you do this. Once again, does not cost anything, just no additives, just a simple centrifuge, and you can get injectable PRF. So when we simulated what we are going to reintroduce, the PRF plug with the disc cells that I have shown have been grown in patient's own platelets. We find that the cells not only are alive, but grow out of the plug. So this is the plug, and the cells grow out very nicely. This is day 7, this is day 11, and day 14. What is interesting is if you look at this plug with cells and this plug without cells, the plug without cells disintegrates. The plug with cells grows, and this is the histopathology of that plug. You can see this is reported not by me, by a third pathologist who is a musculoskeletal pathologist. So she is quite happy that it has a similar appearance to nucleus pulposus. So we are almost being able to grow a nucleus pulposus in the laboratory. Okay, these are various other pictures. So I think the next step we should all consider is to recover cells from the throwaway disc fragments and re-inject it once the annulus heals. Once we start doing transforaminal endoscopic discectomy, the annulus I expect would heal in about a month or so, and that's when we can reintroduce these cells in the PRF plug into the disc, so that the disc height is maintained, the disc environment is maintained, there are less cytokines, inflammatory materials being formed, and the hydration of the disc will probably reduce the annular injuries. Moreover, the disc cells are very robust. So even if the tissue is kept in the medium, in saline for 5 days, we can still recover cells. And this is very unique. This has not been published. Most of the studies that have been done are for non-degenerate discs, say grade 3 or so. We have been able to recover cells even from a very degenerate disc. So we need to remember that degeneration is not a one-way street. These progenitor cells have been captured by the collagen. Once you let them out, they once again start behaving like progenitor cells. Okay? So grade 4, grade 5, grade 6, we have got good growth. So what are the myths? Aging is gradual dehydration, whereas when there is structural failure, annular tearing, that's when degeneration sets in. I just said potential for regeneration is there in the degenerate disc itself. Removed and wasted disc fragments have live cells which can be recovered, and symptoms are not image dependent but are a chemical reactive cascade. We have been able to grow pulposus-like tissue in vitro in our lab, opening the possibility of cell therapy. We are waiting for regulatory approval from DCGI. And finally, DAY-1 plug is a very cheap and easily translatable practice to help healing, not just the disc, but any wounds. Okay? So with these few words, I extend an invitation for you to, this is the place where we have managed to do a lot of our research activities. This is not the only one. We are looking at cold sterilization during COVID. We looked at mucosal immunity. I have our own brace which keeps the top load in line, which is very necessary because of the mobile phones and WhatsApp. The 8 kilogram load is constantly bent forward, putting a lot of flexion moment on the spine. So thank you very much.
Thank you very much, sir. That's very informative and thought-provoking. Any questions?
AVN, this is between you and we have just started a study. DAY-1 plug is platelet-rich fibrin plug. There is another process whereby you can lyse these platelets, okay, and make it a big like a short-acting insulin, a high dose of growth factors. So we use that platelet lysate, which is also again easily translatable. But I don't think I will, because the scientists want me to study it properly before I start speaking about it. Yeah. I think Dr. Gore unfortunately is not here, but he is excellent at placing the plug exactly at the annular tear. He once again goes in with his scope and puts on the annular tear. So 1 or 2 are inside and 1 on the annular tear. We can do it. I've done that, liquid PRF. Okay. The only problem with liquid versus steroid is liquid PRF, the tension lasts for 24 to 48 hours. Long term, the patients are excellent, especially for young people. I very rarely use steroids now, almost zero. I think we get about 1 million cells at 4-week stage. Okay, 1 million quality cells at 4-week stage. Studies that cell therapy studies have used 5-6 millions, but they have not used disc cells. I am saying I'm taking native cells and putting them back in the same place in the same patient, instead of taking stem cells from somewhere or bone marrow cells from elsewhere. Because these cells are used to being in the hypoxic environment. Their HIF is always turned on. So, but I may be, I have to come back. Once I get regulatory approval, the proof of the pudding is when it works. Any description. No problem. So that's what, it's a myth that we have, that once a disc is black, it needs fusion. It's a one-way street. No. You take that, you release the cells from the, it's like any human, when we are used to doing only one skill, we do only that and stop at that. But if we get a bigger, as soon as you open the collagen, you break down the collagen, the cells are very robust. They grow nicely. Yeah, PRP in knee joint has been used very widely. And yeah, but yeah. No, this is because, for example, if you do arthroscopy and then put PRP, the pain of the arthroscopy will mask the pain of the PRP. So we are doing an endoscopic discectomy and then putting PRF. Okay. Just a quick point, PRP, there is advantage that you take 100 ml of blood, 50 ml of blood, so you get more platelets. Okay. No, we get, in fact, we are doing a study. Once again, it's a little bit premature for me to talk about it, but we are doing a study because, we work on a lot of myths. People have just handed down things. For example, you should not use Indian style toilet. You should not sit on the floor. Okay? All this has to be measured. And we are eminently, because we are doing endoscopic discectomy under local anesthesia, we are able to measure it. I don't know if Bhupesh was around. We have started doing activities in the operation table and measuring the pressures of the disc. And it doesn't move very much from 80. 80 becomes 85. For example, if you do a Mackenzie's, it becomes 85. So I said, how come the Mackenzie's is increasing the disc pressure? It's probably because it's pushing it forward. It's pushing it away from the posterior dura. Ethical, yes. Ethical issues really would have been very strong, but fortunately a similar trial has been done in US and in Europe with recruitment of about 200 patients, okay, over the last 8-10 years. And China is very quick. China has published it already. So although we started work before, I'm still stuck in Delhi because they cannot understand the language of cell therapy.
Thank you so much, sir. A small memento.
I think Bhupesh and Omkar are there. We can bother them with all the questions. Thank you.
Now we move on to our next talk. Dr. Ibrahim Musa is joining us on Zoom from Nigeria. And Dr. Ibrahim Musa has got solid experience in using standalone cages, so without screws. And Shiraj knows him, he's close friend, so I allow him to introduce Dr. Musa to the audience.
Okay, Dr. Ibrahim Musa is a neurosurgeon, and he's a senior neurosurgeon working in Nigeria as well as in Central Asia. And he's an excellent surgeon, excellent endoscopist, and I think before 2 years we met in Kenya, and we did some the screw placement cases. So then he got very interested in just putting the transfemoral cage, which we just designed the new variety. And after that I realized that he used to send me many number of cases. So let us hear from his experience about standalone transfemoral cage. Dr. Musa.
Yes, sir.
How are you?
Good morning, sir. How are you?
Very fine, very fine. Thank you.
Happy to meet you.
Yeah, so you can start your video. We all are eager to listen to you. Thank you.
Screen sharing? How do I start the screen sharing? You have to enable me to screen my screen.
Yeah. You make
Okay, I can go on?
Yes, you make him host, yes, yes. Fine.
Okay. Okay. Thank you. Screen sharing files. Dropbox. Desktop, yeah. Okay. Yeah. Do you see it? Okay, I'm searching now. Good morning, all. Here in Nigeria, it's just around 5 o'clock, and it's raining heavily. I believe in India also it rains heavily. So I'm starting my personal experience with lumbar stand-alone spacer due to reduced disc height resulting to lumbar foraminal stenosis. That is indirect decompression. how did he start it? Oh my God. Yeah. So it started all in April 2021. And in August, then I started diffusion actively. I met Dr. Munsi Shirat Ahmed in Turkey, in Bursa, and then later I followed him to Kenya, and he showed me very wonderful ways of doing endoscopic spinal surgery. I used to be an open surgeon, but after seeing how endoscopic can be done by the teaching of Munsi Shirat Ahmed, and then I picked interest, and this is how it all started. And then the reason of going into a standalone cage, as this is the topic I'll talk on, is nothing but here in Nigeria we have a lot of elderly patients who have some neurogenic pains. And these elderly patients, we saw them out, especially those without osteoporosis. And then I started thinking how to help them, because doing big surgery for these patients, it will not solve. Rather, you will even endanger them. They are more morbid, you know, with some other lesions. And then the second reason is post-surgical instrumentation complications due to hardware breakages, failures in very stable spines, and then adjacent segment diseases, and obese and very huge patients. In Nigeria, here we have a lot of patients who are extremely big, and these patients sometimes putting screws or doing even more bigger surgeries, it will lead to excessive blood loss, infections, and a lot of complications we do see. So this is what really triggered my reasoning. This patient might benefit from a very simple, minimally invasive indirect decompressions. And then, of course, I came across the horror of metals and understanding the concept of lumbar spine surgery. Then I understood that, you know, gradual approach to the spine, it solves a lot of problems, not just going and then instrument the patients the way you want. I saw a lot of wrong interventions, you know, wrong surgeries, wrong concept of spinal surgery understanding, and what have you. Like here, as we can see, these are all complications that I used to see operated elsewhere. We can see here the spine is being screwed, and some of these screws is not only here in my country, Nigeria, but it's worldwide. We see them coming from all over the world. When they come, what to do next? So we can see here limited knowledge of anatomy or even the pathological understanding of the spine. And of course, I don't know. Is it like in this little cartoon I have seen, bless me, Father, for I have seen last night I killed a politician. And then the father was saying, my daughter, I'm here to listen to your sins, not your community service work. So are we doing community service work, or are we just, you know, spoiling the spine? While doing endoscopic discectomies and percutaneous fusions, then I went through different literatures, and then this literature caught my attention on stand-alone spacer or lumbar region. And then I got this literature, and then I also came into my own surgical, especially ACDF, anterior cervical discectomy and fusion. Before, anytime when we do an ACDF, we used to fuse. We remove the disc, we put spacer, and then we put a plate. But later on, we start applying just stand-alone cages. And these stand-alone cages, they really, they work fine. So then we started thinking, okay, if we can put a stand-alone cages and then it works fine, and then coupled with this literature, of course, the stand-alone cages also should work on the lumbar region because the cervical area is even more mobile than the lumbar region. But we understood that, of course, the weight bearing of the lumbar region is far more than the cervical. So these are our cervical stand-alone cages. And these cages were put, years, and still the patients are okay. As you can see here, these are the LCDFs we did, and this is what encourages us also, after reading literatures, to go into stand-alone cages. Apart from that one, other post-instrumentation complications just keep on coming. As you can see in these pictures, this was my surgery. I operated this and put expandable cage, open instrumentations, but later the patient came with this lesion. You can see foraminal stenosis due to a bone growth here, and the patient kept on complaining. And I said, oh, okay. Even after posterior instrumentations with your cage, still patient will have complications. Or like in this patient, we can see he has a broken screws and the cage is, back out, and he was operated in an advanced country. So all these cases, they keep on coming, and then I started thinking what to do. Then almost at the same period, the Mission Spine Gores and Girish serial lectures came in, and it broadens my spine vision and understanding of the concept of the spine surgery. By that time, I was able to do fusions, studying the anterior, middle, and posterior columns for possible stand-alone cages. And then I contacted Dr. Shiraz Munsh Ahmed, and he got me some various cage sizes. And this it has gone a long way to continue our research. And still, we are reading our literatures, we are seeing the best way to approach the lumbar spine without heavy instrumentations. Then we made a series of attempts with documentations based on strict patient selections, and of course ethical issues, including recorded patient consents. And then when everything is okay, then we started the stand-alone interbody fusions. As you can see here, we put a cage initially. I remember this patient. We went through the left side, we inserted a cage, and then the symptoms of the left side subsided, but still she was complaining on the right side. So we went again, we inserted another cage, and then the patient no any complaint, and she does come up for follow-ups, and we are still monitoring her. Then we started, aggressive again patient selections, and we started broadening our indications, our contraindications, and in few selected cases, I do endoscopic decompression followed by stand-alone cage. For example, on this patient, we can see, of course, the M plates, the kissing M plates, but we can see the M plates, they are not that very much damaged. But we can see posteriorly here there is some stenosis. So we did interlaminar decompression and then followed by spacer. Or in this one, the patient came purely with left side radiculopathy. So we did transforaminal decompression. Of course, she also had the kissing M plate. So we just jacked the cage, the interspinal space, and the patient up to now is being followed up and patient is doing fine. And then there are some patients, and few cases, after jacking up the sagging and weaker facets, the offending pain generator is seen. Like in this case, the patient came with radiculopathy and then had kissing amplettes. And we said, okay, it's a little elderly patient. Let us just, since the back was stable, let's just put the spacer and see what happens. And then we inserted the spacer, and then still the patient was complaining of his radicular pain. And when we did a follow-up X-ray, then we saw an osteophyte just compressing the transverse nerve root. And then we went endoscopically. We drilled the osteophyte, and since then the patient became symptom-free. So this is one of the advantages I have seen of the. This is how we were drilling that osteophyte that I've shown, and now we can see the freed transverse nerve root. Just a moment. Yeah, so the osteophyte came here and then sitting on the transverse nerve root, and we drill it out, and the patient now is symptom-free. So the standalone spacer really helped us to diagnose the patient, because here in Africa, sometimes when you tell the patient to do all the modalities of the images, you find it a little difficult because of financial issues. Otherwise, you could have done CT scan and everything before even going and put the spacer. Yeah, and in most cases, we use both manual reamers and bendable gore curettes for end plate preparation. And most importantly, the end plate shouldn't be breached. You have to have an intact end plate. Like here, I'm using the manual reamer, and then to prepare the end plates. And then we followed by curettage, and this is the bendable curettes we use to prepare the end plates. But the most important, also from our experience, is don't damage the end plates. Keep the end plates intact. And this is how the end plates look like after reaming and curettage and all it takes. Now from this one, when you have your end plates so well prepared, yes, you can insert the cage. And then the cage insertion should be very much accurate, and you should align it. There's no way of making the cage, like this. It shouldn't bend. It should go straight. It should align. And when you get the alignment, use your C-arm, both AP, lateral, and oblique. And you see it well aligned, and then you insert it, and you'll have a desired result. And then sometime, instead of using the bone chips, we use analogous bone graft. We can use UBE, biportal endoscopy, or monoportally. It all depends how we want it. Like here in this case, we can see we went via UBE, and we can see the spinolaminar junction, and we are taking the bone graft and then inserting it into the cage. And this one, it gives a little advantage. How it reduces the cost to the patient, and we are still studying it. We feel like it will even have a more fusion rate than the artificial bone chips. Yeah, and then of course we align the cage sizes with the C-arm, and then we go straight and inside the cage. Yeah, this is the process we do follow. And yeah, so this is it. And if and when we need a really big cage with analogous bone graft, UBE is an option in standalone spacer. Sometime I would like to have a really big cage, like in this patient. The bullet cage, it goes like oblique like this, but I would like my cage to have the shape, the anatomical shape, and in that regard, I use UBE cage insertion, and this is how we see our cage. Like in this one, we can see it is the bone chips we use. You can see the particles of the bone chips, artificial bone chips. We strictly follow clinical manifestations, not radiological images. We follow the symptoms. What patient tells us he's having the problem, the dermatome, this is what we target. As you can see in this patient, he has scoliosis, but his symptom was only L4, L5. And we just follow the dermatome and then make the indirect decompression, and the patient still is fine. And then in some cases, we have some previous surgeries being done with implant breakages. Like here we can see this patient was a young man. He's a doctor and he got implant elsewhere. Then the implant, broke, and then he was having kissing implants and with radiculopathy, with back pain. So when he came, we said, okay, what we can do, we can give you an indirect decompression, and then we leave you with the implant, or you want to remove it, okay. And then he said, okay, since his middle and posterior columns are intact and he has a very good implants, we went and we inserted the stand-alone cage with analogous bone grafts. And till now, the patient he's happy, he's a gynecologist, and he's operating his patients also. Like also in this patient, as you can see, he's also a doctor, a physician, and he had instrumentation about 7 years ago elsewhere. But all these 7 years, he was crying of pains. And he's very elderly, he's about 84 years old. And so when he came, we said, okay, we saw the foramen was a little bit sinuous. We said, okay, let's do foraminoplasty for you. He said, okay. We did endoscopy foraminoplasty, but still, he said he had a little relief. But anytime when he tries to walk or to stand up, he used to feel a very sharp pain. We did dynamic X-ray, everything was okay. We said, okay, let's do a cage insertion. And we inserted the cages. Initially, we inserted one cage, one dermatome. And then later still he was complaining. And then we found out the upper anatomical region still had stenosis. So we went and inserted the other cage. And since then, the patient is happy and used to use it at home and no complaint. So this is the value of stand-alone cage from my own experience. But of course, you have to select your patients. For example, in this case where there is spondylolisthesis, or in this case, of course, we don't expect stand-alone cage to work. Or here, when you have a degenerative scoliosis, well, we try to avoid it for now, since still now studies is going on. Or here, where you have the implants are not very healthy. Yes, this is one of the mistakes we made. We couldn't analyze how it is. We just went and then we inserted the cage. Then later the patient came to us. We can see even the case has somersaulted and looking up. She came with her pain, so we had to go open, readjust, and put more bigger cage and then put screws. So the complication of the cage in the presence of eroded implants, this is what, as I said it, what we got. Hello?
We are listening to you, Dr. Ibrahim. Please continue.
Hello. Shall I go ahead?
Yeah, please.
Yeah. So this all this one should be taken into consideration before going into standalone cage. So of course, these are our contraindications. If you have modic changes, Schmoltz knots, grade 2 and above spondylolisthesis, gross facet joint effusions, trauma, spondylodiscitis, young and active patients, absence of middle and posterior columns or damage due to previous surgical interventions, and then osteoporosis. We try to exclude them from standalone cages. And these are our results from September 2021 till date. We had 38 standalone cages, and then a single standalone, 29, about 76.3%. And then bilaterally inserted single level, about 15%. And then standalone at 2 levels, about 7%. And then revisited with screw insertions, about 7%. And the cane subsidence, yes, we saw in one patient, it's about 2%. But then the case somersaulting, like the one I have shown before in one patient, and we have never experienced a back out or migration of any cage. So as I have said it, we are still in the research period at our center, including application of analogous bone graft versus artificial bone chips in standalone cases, cages, transforaminal bullet titanium cages versus UBE PIC cages in standalone cages, and the effectiveness of the fusion between analogous bone graft and then the artificial bone chips. So still we are documenting, we are recording, and we are taking our patients, we are reaching out to our patients, and they are coming to us. So this is one of my patients who had standalone cages from the initial time we started. And when he came on wheelchair with back pain. He couldn't do anything, but now we can see a very happy patient. So we are all happy for him. And all I can say, this is my little experience. It's too early to make a very big judgment, but we keep on informing the the audience, and then seeking advice from other colleagues how to go about it. So all I can say is namaste. Thank you so much, and my appreciation goes to Dr. Tin Koch, Dr. Gore, Dr. Munshi Shirat Ahmed, and Dr. Girish Tatar for showing us how to do this masterpiece of surgery. Thank you so much.
Thank you, Dr. Ibrahim. Sorry for waking you up at 5 o'clock in the morning, and it was a very informative talk. But then this is a... Hello, can you hear us?
Yes, I hear you.
Are you free to take some questions?
Yes.
Sure. The thing is, this is a totally new concept for most of the people here. Standalone cages is something which is, we think, forbidden or maybe having some problems, because so far we have not imagined anything putting a cage without a screw, without a stabilization. So yeah, as you also said that still it's initial stages, and we are also keeping our fingers crossed, because this will be, if things work out well, I think this will be some sort, not less than a revolution in spine surgery. Any questions from any audience?
Hello, Dr. Musa, Dr. Bhupesh.
Yes, sir.
Yeah. In standalone cages, without any anchoring device, would you expect that cage got back out and in the posterior structure, facet joint complex? So how good back pain relief will get with only standalone cages? Because facet joints are also arthritic in degenerative spine. So what do you think?
Yeah. Thank you. Yes, we all put all this into consideration. The back out subsidence, and then the structure of the posterior and middle column. I have said it, the kissing implants and then the foraminal stenosis sometimes is due to the sagging of the joints. And once you can jack up the space, the anatomical structures, they will come into, they will align themselves. And so far, we haven't seen any back out of 38 cases we have done. Yes, we have seen subsidence, and yes, we have seen our patients are getting relieved. And as I have said it, we are still monitoring. We just very early, only 38 cases. So, and we believe with the analogous bone grafts, I think we will get more fusion. The fusions are coming up, and we are seeing it because we are doing CT scan, we are doing MRI, we are doing X-rays, and we are seeing, some few encouraging results. So we keep our finger crossed also. But any person who is doing it, he should know that if he has any problem, he can quickly go in and then, take care of his whatever he's doing. Shouldn't leave the patient just like that. So you have to be good in open spinal, surgeries before you can go into it. And we have taken ethical clearance, and the patients are well informed that if anything goes wrong, we'll take you back and you'll have an open spinal surgery. And so far so good.
Okay.
Thank you.
Because they came up with the Steffi plate in Alif surgery and Olive. Even initially they recommend the standalone cages, but now gradually they are moving. Just they say posterior percutaneous fixation along with cage fixation is good because the posterior facet joint complex are overburdened and just because of distraction doesn't serve purpose. This is that's why I just want to acknowledge you. Okay.
Thank you.
Ibrahim, do you do the surgeries
Yes.
under anesthesia or general anesthesia?
Local.
Okay, so bagging that cage inside is not very painful to the patient?
No,
Okay.
it's not. Local anesthesia, then when we want to, like hit the cage to sit down very well, we advise the anesthesiologist to give you a little sedation, cautious sedation, and it's fine. Usually standalone cages with the end plate preparation is less than 30-45 minutes. We are done. So a patient tolerated well.
Okay. Okay. Any more questions? Yeah, there's a couple more. Just hold on.
Thank you.
Yeah, you have more question, Dr. Musa.
Yes.
Dr. Musa, if I'm right that you are using two techniques to put in the cage. One is from through the UB from posterior aspect and one is transforaminal, right?
Yes.
So how big a cage are you able to put from posterior using UB without removing the facets and all?
Oh, there's a partial facetectomy. 12.
Partial facetectomy you do?
Yeah. Partial.
Okay, fine.
Yeah. Inserted 12 comfortably.
Okay, and see, I want just to add one thing more. That Dr. Musa is a very senior spine surgeon, and he does around 2, 3, 4, 5 surgery in a day. So like this is not something that he is just not experienced or a young guy just doing the numbers, but he is very well experienced in routine open spine surgery. So let us see how the things goes, because we are also doing some of the cases. Some of the cases have failed also, but let's see. Even the standard posterior instrumentation, they have the complications. So we'll come out with this more data, and we'll be able to know how the things work. Especially this is very important for very old and fragile patients, those who are having very limited mobility. So I was really waiting for Dr. Nadkarni to give his comment. Yeah, so because we did some cases in DAY-1 also. So I just wanted to know that how are the follow-up of on those patients. Thank you.
Yeah, now I call upon Dr. Shiraj to present his talk on cages for endoscopic fusion.
Shweta, your password is required. Shweta, password.
Thank you, Dr. Musa. Hello?
Thank you.
Yeah, thank you so
Yes,
much, sir.
sir.
Yeah, we will get.
Thank you.
If I missed your memento and your certificate, we'll make sure that it reaches you in Nigeria. And we'll
Thank
be
you.
collaborating with you in future as well. Thank you so much, sir.
Thank you, Dr. Musa.
Thank you. Thank you.
Yeah, we are eagerly.
Thank you all. Thank you.
Yeah, we are eagerly waiting you to see in presence in India.
Yes. Yes, I will come one of these conferences. Surely, you will see.
Thank
You know, sometimes if Nigeria to get visas, it's a little bit a challenge.
I know.
So
Yes.
that, yeah. But otherwise, yeah, I would like to come.
Thank you.
Thank
you
you.
so much.
Thank you so much. Thank you so much,
Thank
sir.
you.
Thank you.
Thank you. Bye bye. Bye bye. Yeah.
Yeah. See, our medical science is something we try to do something new and see the follow-up and coming out with our own experience. Then we can publish, we can share with our colleagues. So these are the all new things which is coming up, and the new technology is required only when you realize that the whatever we have, it has having some issues. So yeah. So now, so now even you see that last this year early start, I come across one American company who has come up with the synthetic bones, and they are claiming that it's an American company, and they are claiming that in 6 month time, the fusion rate is almost 100%, and the entire material turns into the bone in 6 month time. They have all the data. So now you see all these things where it will help, because if the bone the fusion is so fast, so then the chance of a cage migration or any other complication will be very less. So with the advancement of the technology, the new things will come up, and we can just go ahead with the new ideas. So my talk is about doing the how we do the transforaminal cage. So normally we do always with the screws, and the idea is to increase the height of the disc. So the foramen will also jack up, and the nerve root will be free, and obviously we can minimize the posterior midline structure damage. So usually our indication is reducible spinal instability and grade 1 or 2 listhesis without severe ligamentum flavum hypertrophy. I'll just go ahead that how we do it. So this is a pre-operative X-ray. So you can see this was a already operated patient, and you can see this was a very severe foraminal stenosis at L5S1. So now you see what was happening, that so normally what we like to do is we just do it under local anesthesia or epidural analgesia. So what we do, we just put the epidural catheter, but the needle entry we always do with the under local anesthesia. So you are very sure that you are not going to hit the nerve. And so what was happening with in this patient, that the moment we were just trying to go inside the foramen, the patient was having the very severe radicular pain. So there are two reasons for this. Either you are touching the nerve root directly, or maybe you are touching the fragment, and the fragment is pushing the nerve. So what we did for this particular patient. So how you can do this fusion also with under classical epidural analgesia. So we do it at L2-3 levels, and so you're putting your needle at L2-3 level, and then you can just put the catheter. You use the C-arm. So C-arm is an excellent tool to confirm your the placement of the catheter, as well as you put the dye. You know exactly where your medicine is going to go. This is very, very important, because sometimes the catheter, they tend to migrate, or is not reaching at the right area. Then you fail, and you have to convert the patient from epidural to general anesthesia or any other technique. So this is very, very important. Dr. Pupes is with me for this case. So here he's just trying to explain that what was our plan. So you can see. So this was we already discussed. So in this case, what we did, we put the screws on the opposite side, and then we just did the destruction. And once we had little space, then we put the. So you can see the needle is still there. We have not put the endoscope. So now you see now. So now we put the dilator and the scope inside. So then we did just the endoscopic decompression. So you see this the transforaminal way you can just you can do the end plate preparation, and you can finish most of your job, and then you can start preparing for the cage. So then after doing the discectomy, we kept the sleeve just there. And then we put the screws on the same side also. Then you can see we have some different instruments. So this is this is a bendable curette. So this you can pass through the endoscope, and you can do the end plate preparation also under vision. So like you see, this curette is straight, but if you when you bend it, it can bend up to 90 degrees. And this is a very sturdy also. So you can see so you once you just screw it like this, it just turns. So like you can also fix the angle, and you can work on the end plate. So now see how we decide about the size of the cage. So like we use all the different dilators. So this dilator, once you put inside the disc space, it gives you the idea that what exact size of cage you require. And you know that we do this all under local anesthesia, sorry, epidural analgesia. So it's epidural analgesia. Patient is awake. Patient is able to tell you about the motor movement and everything. So initially we used to use the nerve protector. So like it's like the half round device. You just put over the dilator, and then you just put there. Then you remove the dilator, and you can put the cage over the dilator. So I have used the mix kind of the videos. So it's not same for the same patient. It's a different patient. So then you can put the cage. So this is exactly a bullet shaped cage. You can put over through the guide wire. So this will exactly go inside the way you want. And the beauty about this putting the cage transforaminally is you can place the cage exactly in the midline. So that is something very good. So you see, these are the two ways we do it over the guide wire. So this is the guide wire, and under X-ray guidance you just do it. The other way is we sometime we just pass it, put the dilator over the facet one by one, and then you just put the cage. So this both options are available. You can select whatever the way you want to do this. And you see, once you have dilated the trach, so you are literally, you are not worried about the nerve injury. One is the shape of the cage is a bullet shape. So like you see, the dilator is also having the same kind of tapering. So what happens? It just retract the nerve when it comes to you. So the idea is to remain very close to the facet as much as possible. And we have done even the cadaver studies also. So even taking out the cage is also possible. You can go to the same spot and you can just put the cage holder, and it's quite easy. So this is the cage what we have developed. So we have our own design, and these are the different 12 size of the cage available. Now we have 14. So it starts from 7 to 13. 7, 8, 9, 10, yeah, to 13. And the different sizes are, I think, 22 and 26, or yeah, or 26 and 30, I think, yeah, 26 and 30, we have the option. So for that particular case, so this is the final position. Then you remove, and you can see this is the cut the patient is going to get. So you can see this is the excellent way of putting the cage. And this was a young girl of having the spondylolisthesis. And you see this is the X-ray after 2 months. So the good thing is, like, your placement is very nice, and you can exactly put this in the center. So this is already, we have I think 4-year follow-up for this particular patient. And so I'll just add some more slide where what the next we are planning, or we are trying. So about the standalone cage, so we already had this lecture from Dr. Musa, and we have some colleagues here also. Dr. Ankit is also, he is doing, he has done some cases. And so like you see, this is the complete picture, how you do. So this was a 82-year-old lady, and we did it with Dr. Gore and Dr. Nadkarni in their one. And so I just wanted to ask that how is the follow-up of this patient. This was done before 3 months or something. So now we are coming up with the new the expandable cage. So we have made all the new instruments for the expandable cage also. So we have the expandable cage of around 8 millimeter. So we have done already done the cadaver studies. So these are the instruments, and these are the for the end plate preparation. So basically this will go through the doing the partial facetectomy, and this will go through the PSLD scope. So you know what we do, we just do the PSLD, we just do the decompression, and once everything is prepared, so like whatever you know you want to do, you can just finish. And then after that, this expandable cage you can put through the bigger sleeve. So what we do, we put the cage outside and put the cage holder inside, and then just screw it. So we have done some initial cadaver study, and right now we are working on it. There were some issues we realized, so we are sorting out those things. So our set and everything is ready, but those issues. So mainly the issue is complete visualization. So like you can see here, the putting the cage by the way of transforaminal, it's not completely under vision. So now we are trying to make it completely under vision. So we are coming up with some new scope which will be exclusive for the fusion. So it will be a bigger size of the scope, and everything will be under vision. So the cage will pass through the channel of the scope. So and for most of the other patients, those who are having the very severe stenosis and multi-level issues, so we are very thankful to Dr. Nadkarni sir, because he has invented this hybrid fixation technique, where what you do, you put the MIS guide wire on through the pedicle, and then you just connect this guide wire incision. Then you put the serial dilator, and you do the fasciectomy. You do all the disc preparation, and you put the cage through the same thing, and whatever remaining decompression you can just do with the tubes. So this is also one of the wonderful technique, especially when you have the posterior stenosis instability, or you have the facet related issues. And the excellent idea is the facet joint itself will provide you the bone graft. So this is one of the my favorite also. Of course, I always do it with Dr. Pupesh, but especially for more complicated or more difficult patient. So we can do the 2 level, 3 level, and this is all we do it percutaneously. So like even the most standard company, they don't have the option for do the MIS for more than 2 level, but we always do even we have do up to the 4 level also. So you see this is the picture, and this is the patient incision. So definitely the fusion is something which is coming up at a very high speed in the endoscopy. So there are so many new techniques are coming up. Especially I like to work on this endoscopic assisted fusion. So you have the option, and especially under vision. So UB is one of the very good technique to put the cage. And recently last month I was invited in China, and I did one case about the uniportal decompression, but there I see 2 or 3 cases they are doing this UB assisted fusion, and that is an excellent way, and I could see the guy is finishing the entire case in 45 minutes. So this is something, and they have developed the new set of instruments, so I already bought all those instruments also. So that way I think in future the most of the fusion will be coming up through the endoscopy assistant, and especially under vision. So this is definitely a future, and especially like with this we'll be able to cover almost 100% of the degenerative spine conditions. So till now the fusion was something in the kind of experimental, or like we were learning, but now the future looks very bright. So these are the advantages, and definitely this is way better than doing the open fixation. Thank you.
Thank you, Siraj. This is a wonderful talk. Any questions, audience? Now you can imagine that with the other techniques of P-leaf, T-leaf, and recently the O-leaf, the amount of tissue dissection, the exposure, you are getting away with most of it, because the idea is the same. You just have to put a cage there, out of bring the end plate. So if it is possible through a minimal incision in a way which is less morbid to the patient, you can't imagine O-leaf and doing the same procedure. So this is going to be the future. I'm sure that many more cases will be done, and many surgeons have started doing it. And naturally, it will be the one which most surgeons will start doing henceforth. Yeah, thank you, Siraj. Thank you. Any questions now?
Sir, actually, you do it for listhesis cases. So how do you address the posterior instability? Because the component your only focus is to put a disc spacer, but there is a lot of instability happening at the pedicle, and there is already grade 2, grade 3 listhesis. So if you don't reduce, then that there might be means nerve impingement. So how do you, because your focus was only on putting the spacer.
No, no, no.
Then how do you address? Do you put a posterior screw and reduce it and hold, or
Yes.
or complementary?
Like we show you the three kind of the cases. One is the young patient, those who are having the only lytic listhesis. So you see what happens in those cases, there is a sliding listhesis. So in sliding the listhesis, it's a reducible listhesis. The moment you put the screws, and so for the MIS system, you have all the option to reduce the listhesis. So what is my criteria for? I will put the transforaminal cages when the patient doesn't have the posterior pathology. So that is a one condition when the patient doesn't have the stenotic component. Yeah. Yeah. The second group of patients, those who are having the degenerative listhesis, and so in those cases, we do this technique where you dock on the facet and you do all the related work. So you can do even the bilateral decompression. You can do the laminectomy. You can remove the phlegm, and you can see exactly. So in those group of patient, we prefer Dr. Nadkarni's technique. And so here also, what we do, we put the guide wires first, and then do the decompression. And we already remove one of the facet. So then once you put the screws, you have the option to reduce, and whatever you can reduce with the open technique, the same way you can reduce whatever the way is possible. And since you have done the posterior decompression, things are very easy.
So but after you reduce, you keep the screws, or you
you
have to
we keep the screws. Yeah.
With the
see, I don't do much of the standalone. No,
you don't do standalone.
No, not much. So only few, and those who are like specially indicated for very old fragile patient or something. But otherwise, I don't do much of the standalone. No, definitely not.
I just have one question. So in trans PSLD, so can you insert the cage through the cannula? Like, how do you insert the cage? You keep the cannula, or you keep the nerve root retractor and then put in the cage?
So you see, initially I always used to use the nerve protector. So this I already show you here. That initially this was a concern, because anyway the putting the cage is a blind, and it's under X-ray guidance. So initially I used to put all the cages under with the nerve root protector, and then see, since in some of the patients we started using the epidural analgesia, and the most important thing is you already have created the trach. So now what we do, so like you see this the endoscope what we are using, so it's having the dilator the 6.3 or 7 millimeter dilator. So now what I do, I have 8.4 dilator, I have 10 millimeter dilator. So at least 8.4 millimeter dilator, I just tap it inside. So when you are doing, you have already created a very good space, and the dilator is having the same shape as what our cage is having. So this cage is a very tapering bullet shape. So now you are already inside the disc with the dilator. So in that process, once you know that you have not created, and see, once you remain close to the facet, and you have the bullet shape. So like we have never seen, even doing the many endoscopies, even with the collapsed disc, when the disc doesn't have the good space, still this dilator, they are able to go inside the disc without any issue. So putting this dilator while the sensory epidural, so we know that actually we are not doing any touching the nerve or doing any damage to the nerve. So initially I used to use the nerve root protector, and then we realized, so like then we just use, because you have already done the same process of dilatation, so the cage just goes very smoothly.
So you put the dilator and then take the dilator out, and then under C-arm you do it.
Yes. So like you see, I think I show you two techniques. One is this one. So this one is you use the same serial dilators of the MIS.
Shiraj, we'll rush through. We'll take the
I think we can talk.
Yeah, Shiraj is going to be here. Sir, 1 minute. This one quick talk by Bhupesh is leaving now, and the OT, they are also ready.
Okay. I think we can have the one.
Yeah, we can just, sir, we'll come back again.
Hello?
Yeah, Mahisha.
Yeah, good morning.
Can you give us 10 minutes?
We are waiting since 20 minutes. And we have to finish 2 cases.
Okay.
And I have to leave by 4 p.m.
Yeah, doctor. Okay.
But anyway, we will manage.
Sure. Dr. Bhupesh is going to talk about uniportal and biportal endoscopy and what are the situations where either of them can be used.
Yeah. Yesterday we have many questions, which technique we need to use and what are the advantage and disadvantage of particular technique. So today we just discuss which one is better or which one is not. But in conclusion, you will realize that all are same. So for the cauda equina syndrome, we initially say the transfer endoscopic technique is not good, but we have consistently produced the result. In cauda equina syndrome, almost all our patients are recovered with endoscopic technique, either interlaminar or transforaminal. So I'm just presenting the case. This is an 85-year-old male with severe bilateral leg pain, not able to stand more than 15, not able to stand since 15 days, loss of urinary control since 5 days, bilateral lower limb numbness and constipation. You see there is a huge cyst in the dorsal area, and it's compressing thecal sac and sacral nerve roots also. But he's 85 years. On arrival, we found 80/40 blood pressure. Patient has silent MI based on prop I and raised BNP. He was treated in ICU setup for 1 week. We took patient in OR and did interlaminar endoscopy under a local anesthesia. And we kept epidural catheter if need arise. But patient tolerated surgery under local very well and had complete pain relief post-op. Catheter was removed after 1 week and his bladder function returned. You see this. Sorry. So this is dorsal cyst you see. We removed the cyst from this area completely and we decompress the thecal sac, both sides. And bilaterally we completely decompress both nerve root. Yeah. And immediately post-op, patient is moving his leg because we did under local only. So this patient completely recovered. Again, 34-year-old male with severe low back pain with bilateral leg pain. Right is more than left, is right partial foot drop, bowel bladder involvement. And you see the X-ray, they're stable, but in MRI, there's a huge herniation at L5, S1 level, up, down, everywhere you can see the disc fragment only. So again, we went interlaminarly and did interlaminar endoscopy. And we removed all 4 huge fragments through interlaminar scope. This is I'm using a transforaminal scope for interlaminar endoscopy because if interlaminar window is very large, you don't need very large scope, stenoscope. You can manage very well with transforaminal scope. So this one is superior migrated and this one is dorsally migrated. So there is huge fragment, almost 10 to 12 centimeter long, and you see the post-op MRI. There's complete decompression of thecal sac and nerve root also. So he had a complete relief next day. His catheter we removed 10 days and gave a trial on 10th day. Patient bladder function returned within 10 days, and after 45 days he back to routine activity because he's very young. So now this is 45-year-old lady with only retention of urine since 2 days, difficulty in passing stools for 1 week. No back pain, no radiculopathy. So it is a basically cauda equina syndrome mimicking as a conus medullary syndrome. Because without any radicular pain, patient is having only, you see there is a free fragment here behind the S1 vertebral body. Again we went interlaminarly. I'm moving a little quick because we are running out of time and Dr. Mahesha is already waiting for us. So we went between the S1 and thecal sac, S2 nerve root and thecal sac, and we removed that fragment which is behind the S1 vertebral body, and it's just pressing the S2-3 nerve root. This is a complete decompression of all nerve root. So I think you think IL is better, but again, wait. This is again 24, very young male with severe right leg pain since 2 months, not able to stand more than 2 minutes, not able to walk more than 2 minutes, perianal numbness and difficulty in urine control since 4 days. This presented 1 year back to me. This is X-ray patient. MRI, you see the very huge disc and with right leg symptom and urinary symptoms. So we remove the disc. This is a final decompression picture. And we decompress the thecal sac from lateral recess also in transforaminally. If you see there is a decompression, we remove the phlegm from lateral side also, and we did little bit foraminoplasty also. So this now is I think farmer by profession. He's taking all routine weight in his head and doing all the normal activities. So one more guy with 37-year-old male with severe left leg pain since 3 months, foot drop since 3 days, loss of bladder control since 1 day, catheterized outside, and we did emergency surgery on the same day. I think this is Janmashtami. So you see the huge L3-4 central disc here. So within is pain relieved, power improved in 15 to 20 days. We removed catheter on 15 days and full recovery or motor function 40 days. Again, I do pre-op sonography, post-void urine. If urine post-void is more than 100 cc or patient doesn't have bladder control, we don't remove catheter on very next day. We usually keep more than 1 week and then we give trial, because sometimes what happen, we do endoscopic surgery, you discharge the patient and sometimes they may have urinary retention at the home and that bladder capacity is enormously expanded, and then that bladder to recover is very difficult. It takes lot of time. So again one more, let's keep. Then again, which see transforaminal is also good, interluminal is also good. Then still we have one more patient, 58-year-old male with severe bilateral leg pain, right is more than left, again urinary retention 15 days, not able to walk because of weakness, standing time is less than 30 seconds, bilateral partial foot drop. You see the picture. This patient is unique because he has very severe stenosis, again along with very big disc herniation. So we went biportal. We did a unilateral biportal endoscopic decompression. And we removed the fragment from right side axilla also and left side from left side axilla also. So both sides we removed the fragment from L5 traversing, between L5 traversing and thecal sac. And we did complete decompression on both sides. So this is the final picture. So yesterday we did the same case. That guy has very huge central and right paracentral herniation and little bit migrated herniation also. We removed a complete herniation with biportal endoscopy. So this is axilla of contralateral side. So in biportal endoscopy, you have very good freedom of instrument navigation. You know, you can reach to any corner because the scope is 4 mm and your instrument with small instrument, you can reach to any corner. This is a big fragment. So which approach, when and why? So to conclude this thing, it is always debatable which is better approach per particular pathology. But use the approach which is give a maximum result and which you are comfortable most with that approach. But most important thing in caudate venous syndrome is 360-degree decompression of the thecal sac and its descending nerve root. For me, the soft tissue herniation pathology at L4-5 or above, I would recommend transforaminal endoscopy first, because the handling of thecal sac is almost negligible in transforaminal endoscopy. But pathology at L5-S1, I would prefer the interlumbar approach most, because interlumbar iliac crest is very high, or sometimes iliac crest and facet joint is very large. To reach the dorsal part of the disc, it's very difficult sometimes. So in an interlumbar approach, the window is very large, so just need to 5 mm splitting of phleum is enough just to get out for disc. So there is a least handling of thecal sac in L5-S1. And again, always listen to your master, which again shorten your learning curve. Yeah. Thank you.
Thank you, Bhupesh.
Huh? Yeah, 12.5.
Yeah, we'll quickly move to the theatre. If anybody has any questions, please catch him in private.
Yeah, new Torsbide. Good morning.
Yeah, morning, Mahesham. Sorry for keeping you waiting.
This patient is a 65-year-old patient with bilateral claudication. If you see the MRI, there is degenerative listhesis at L4-5 level. Of course, patient has
photographer, please.
Can you see?
Yes, Mahesham, we can.
So there is degenerative listhesis with the severe canal stenosis at L4-5 level. Patient has asymptomatic lysis of L5. So we are not going to fix it because the patient has wide transverse process which is stabilizing it. So we will not be touching L5-S1 disc. So we will plan is to do a interlaminar decompression and a discectomy and cage at L4-5 level, and followed by pedicle screw fixation. Here normally I would have put the screws first and then do the cage, but here because of logistic reasons we are doing the cage first, because everybody wants to see the cage, and screws anyway you know how to put it. Is it clear? Knife. Hello? Hello? Anybody there? Hello?
Yeah, it's clear.
Okay, so I have just taken the CR marking. You can see the needle inside here. So I just taken a marking parallel to the center of L4-5 disc. So basically we are doing a translaminar approach. We go through the lamina to decompress. So today we are going to use a 5.7 mm working channel endoscope from MP Medical to do the stenoscope decompression knife and do the discectomy and cage. So cannula. So I put the dilator inside. Sterile, Allah. So I'll put the नहीं जा रहा है कैनुला. ये टाइट है, कुछ प्रॉब्लम हुआ था. कल केस के बाद कुछ हुआ था. Just hammer it. Just hammer. It's very tight. मैं काम करता हूँ. Okay. दूसरा डायलेटर डालता हूँ. So there's some issue with the dilator, so I will use another dilator. There's some problem with this dilator. Cannula has become little tight. hammer. Hammer करो. Good catch. Tight ಆಗಿದೆ. Okay. So instruments can give you problems anytime. So anyway, I will use a smaller dilator and go inside. दूसरा dilator. ಬೇಡ ಇರಲಿ ಅಂದರೆ just we need CM only for a moment. So okay. So I put the cannula inside now. We'll confirm the level. Should. So that is our level. So I'm quite happy with it. CM out. So we will start the endoscopy part. Irrigation. So we'll be doing a decompression first, followed by discectomy. Light on, please. Irrigation. Irrigation, please. ಅದು ಫಿಕ್ಸ್ ಮಾಡಿ ಇಲ್ಲಿಗೊಂದು ಆಟ್ರಿ ಹಾಕಮ್ಮ ಸಲೈನ್ ಈ ಕಡೆ ಬೀಳುತ್ತೆ ಜಸ್ಟ್ ಪುಟ್ ಒನ್ ಆಟ್ರಿ ಹಿಯರ್ ಮೊನೋಪೋಲರ್ ಆನ್ ಮಾಡಿ ಮೊನೋಪೋಲರ್ ಜಸ್ಟ್ ಸ್ವಿಚ್ ಆನ್ ದ ಮೊನೋಪೋಲರ್ ಮೇಕ್ ಇಟ್ 50 So this is a normal interlaminar decompression what we do. The steps are same. Only thing is we'll be going more lateral and removing the facet and then doing the discectomy. Then end plate preparation and grafting and then cage insertion.
Mahesa sir, please coordinate and the orientation of the endoscopic picture.
Yeah. So I am standing on the left side of the patient. 12 o'clock is medial, the bevel is facing medial, 6 o'clock is lateral, 9 o'clock is cranial, 3 o'clock is caudal. So on the foot switch illi kodi, foot switch, adu 50 ಮಾಡಿ 50 ಮಾಡಿ. So let me see whether this monopolar is working here. ಇದು ಬೇಡ ಈಗ ಆ ಕಡೆ ಇಟ್ಕೊಳ್ಳಿ, ಇದು ಆ ಕಡೆಗೆ ಇಟ್ಕೊಳ್ಳಿ. So first thing is to clear the soft tissues. Okay, make it 50. Okay. Quarter plate ಹಾಕಿಲ್ವಾ? Quarter plate connect ಮಾಡಿ. Quarter plate, patient plate. Grasper ಕೊಡಿ. Quarter plate connect ಮಾಡಿ. So first thing is to clear these soft tissues. So today we are using bones camera, MP medical endoscope, striker shaver system,
Like a cocktail.
and we will try to use this monopolar. If it works, I don't know. Patient plate ಹಾಕಿದ್ರಾ? ಯಾಕೆ ಕನೆಕ್ಟ್ ಮಾಡಿ. ಪೇಷಂಟ್ ಪ್ಲೇಟ್ ಕನೆಕ್ಟ್ ಮಾಡಿದಾ? ಅದು ಏನದು? ಓಕೆ, ರೆಡಿಯಾ? ಓಕೆ. ಫುಟ್ ಸ್ವಿಚ್ ಇದೇನಾ? ಬಾನ್ ಅಲ್ಲ, ಓಕೆ. ಗಿವ್ ಮಿ ದ ಫುಟ್ ಸ್ವಿಚ್ ಕೊಡಿ. ಗಿವ್ ಮಿ ದ ಫುಟ್ ಸ್ವಿಚ್ ಹಿಯರ್. ಸಿಸ್ಟರ್ ಇಲ್ಲಿ ಒಂದು ಆಟ್ರಿ ಹಾಕಮ್ಮ. ಆಟ್ರಿ ಹಾಕಿ. ಓಕೆ, ಆಟ್ರಿ ಹಾಕಿ. ಓಕೆ, ಸರಿ. Can you see the monopolar working?
Yes sir.
Bhupesh is there?
No sir, Bhupesh sir has been left. Bhupesh has been left.
Yes, left.
Yeah.
Okay. He always wondered how it works. Underwater. So this is a normal monopolar cautery which is available in any hospital. And the probe is a 3.5 mm pediatric L hook from Home Surgical. It is very efficient very safe over the bone, but never use it over the dura. So you can dissect, ablate, coagulate, cut, whatever you want to do, you can do. If you want more power, you can increase the power. So here most important step is to define the bony anatomy before we do anything. A light off ಮಾಡಿದ್ದು ಮೇಲೆ light off ಮಾಡಿ. So when we use monopolar, some heat will be generated, but it gets dissipated by the saline. BP ಎಷ್ಟಿದೆಪ್ಪ? BP ಎಷ್ಟಿದೆ? Can you reduce the BP? So can you appreciate monopolar working?
Yes, sir.
So this is the least expensive coagulation you can get, but it is most effective. Anybody disagrees with me? One probe will last you 100 cases easily.
Sir, this probe can we use in the normal cautery that we have?
Yes, it is a normal cautery.
Okay.
Because I did not know which cautery machine is available in BRUNDHAVAN hospital. But I just got my probe.
Sir, this is from Om Surgical?
Yes.
Okay.
So you ask for 3.5 mm L hook, pediatric L hook. They use in pediatric laparoscopic surgery.
Pediatric.
So clearance of soft tissues and absolute control of bleeding is very, very mandatory. Otherwise your field will be bloody and you will be struggling whole day.
Yes, sir. It is really very appreciating and working very fast.
Yeah. And it will not damage the scope.
Good one.
Right now the BP is quite high, so we have asked them to reduce it, but still we are able to work.
Sir, patient is under GA?
Yes. What is the BP now? Yeah, BP is high, but still we will work. So this is the laminar edge, can you see?
Yes, sir.
Okay. Once the BP comes down, the bleeding also becomes less. You can use this to control bone bleeding also. So this is the lateral edge of the lamina. So our bone cuts is, we have to cut the bone here so that we detach the
So right now
inferior facet.
Right now you are over the superior lamina of the lower vertebra.
No, the upper vertebra. This is the
Okay, this is inferior lamina.
L4 lamina.
Okay.
L4 lamina. Can you see this landmark?
Yes, sir.
Can you see this bone?
Yes, yes.
This is the lateral edge of the lamina, which continues as spars if you go up. Okay? So this is the lateral edge of the lamina. So once you make a cut here, you can detach this facet. Is it clear? This is the facet
Yes,
joint.
sir.
Now I have to clear the lower part. So this is the L5 lamina here. And that is the flavum. Yeah, see this is the L5 lamina, is it clear?
Yes, sir.
You see how effectively we can define the anatomy with this. cutter there, एक बार. So this is the L5 lamina here.
Okay.
Is it clear?
Yes, sir. All things are clear. So, sir, you always use this monopolar in the interlaminar cases?
Every day.
Every day.
Every day. Nobody will tell you this because of obvious reasons. Have you heard this before? Have you seen this before?
No, sir, no.
Yeah. So I have many secrets like this.
Sir, open as much as possible.
Monopolar. But I will come only for my friends' conferences.
So we are lucky here.
Yeah, because when Ravindra or Sukumar or Bhupesh call me, I cannot say no. Grasper. So now the anatomy is clear. Is everybody clear now?
Yes, sir.
About
Any
the anatomy?
question?
So once you clear the soft tissues, they will not trouble you later. If you don't clear this soft tissue, it will come in the way all the time. So you spend few minutes here to clear this, to define the anatomy, then it becomes easy. Of course, today we are working with very, very limited instruments, so it may take little longer time. So pardon us for that and be a little patient, because we don't have a good osteotome here to take out the bone. So this is the facet here. Can you see?
Yeah.
This is the facet, tip of the descending facet. Can you see? I will show you in a minute. So this is the tip of the descending. Can you see the facet joint here?
Yeah, of course, of course.
So this is how beautifully we can define the anatomy with monopolar cutter. And it is very quick and very efficient. This is the descending facet, tip of the descending facet here. So the anatomy is very clear. Okay? Osteotome?
Yeah.
So I will see, we have very small osteotomes. We don't have big osteotome, unfortunately. So we will try to do some cutting here. Hit, ma? What did you? Hit.
Yes. Because you're not near the neurostructures there. Maybe the muscle and other
What
things.
is
So you
it?
can take it.
What did you? Okay. What did you?
Mahesha?
Yeah.
You're using which cotton now? Monopolar?
Which?
Cotton?
Grasper.
RF or what?
No, I used only monopolar.
Oh, there is a question that how it is working in saline.
So that you can see here and decide whether it's working or not. It does work. You see the facet joint?
Yeah, yes.
Okay?
Yes, yes.
Okay, osteotome. Okay, bone it kolema. Hodiri, can you come and hit brother? So we'll try to take some graft here.
Okay.
Sarko.
Mahesha, as you're working, we start distributing some certificates because some delegates,
very much.
Yeah, they will be leaving shortly. Okay.
Yeah, no problem.
Yeah, sure. Thank you.
If
we are there.
You want to?
No. We are there.
Ask anything, interrupt me.
Sure,
no
yes. We will be communicating. We are watching.
Yeah.
Just that in between you will find some disturbance.
Okay, no issue. Bonnet papa, brother. Bonnet color.
We will start with distribution certificates because some delegates, I think they are planning to leave. And KMC has awarded 5 credit hours for this conference.
pin. Grasper code.
Dr. Manu. Dr. Manu is here.
Cutter.
Dr. Manjunath GS.
ಅದು ಫೋನ್ ಅಂತ ನಿಮ್ಮ
ಡಾಕ್ಟರ್ ಮಾರುತಿ
ಫೋನ್ ನೋಡಿ ಎಂತ ಮಾತಾಡಿ ಕೇಳಿ ಅಂತ ಕೇಳಿ.
ಡಾಕ್ಟರ್ ಮಧುಸೂದನ್ ಟಿ.
ಓಕೆ.
ಡಾಕ್ಟರ್ ಮಧುಸೂದನ್ HR. No.
ಕೇರಿಸನ್ ಕೊಡಮ್ಮ.
Okay, I'll just see some. Yes, Ravi Mysore. ಡಾಕ್ಟರ್ ಪುನೀತ್.
ಬೋನ್ ಇಟ್ಕೊಳ್ಳಿ.
Sir, Dr. Purushottam Shastri, sir. Shiraj, can you just stand out that?
Transfer. ಇಲ್ಲ ಏನಾಗಿದೆ ಸ್ವಲ್ಪ ಬರ್ ಕೊಡಪ್ಪ. ಗಿಮಿ ದ ಬರ್ ಒಂದು ಆನ್ ಮಾಡಿ ಶೇವರ್. ಅದು ಇದು ಚೇಂಜ್ ಮಾಡಿ. ಸಾರಿ, ಫುಡ್ ಸ್ವಿಚ್ ಇಲ್ಲಿದೆ, ಅದು ಮೇಲೆ ಇಟ್ಕೊಳ್ಳಿ, ಇದಕ್ಕೆ ಕೆಳಗೆ ಇಟ್ಕೊಳ್ಳಿ. ಫುಡ್ ಸ್ವಿಚ್ ಮೇಲೆ ಮಾಡಿ. ಕೀಪ್ ಇಟ್ ಅಪ್, ಕೀಪ್ ಇಟ್ ಹಿಯರ್. ಇಲ್ಲಿಗೊಂದು ಇದು ಹಾಕಮ್ಮ, ಮತ್ತೊಂದು ಬಟ್ಟೆ ಹಾಕ್ಬಿಡಿ. ಅದು ಸೆಲೈನ್ ಸ್ವಲ್ಪ ಪ್ರೆಷರ್ ಕೊಡಿ. ಪಂಪ್ ಇದೆಯಾ? ಪಂಪ್ ಜಾಸ್ತಿ ಮಾಡಿ. ಹಾಂ, ಪ್ರೆಷರ್ ಇಲ್ವಾ? ಇದು ಲ್ಯಾಮಿನಾ. ಹಾಂ, ಅಪ್ಪರ್ ಲ್ಯಾಮಿನಾ. ಕಟ್ಟರ್ ಕೊಡಮ್ಮ. ಅಪ್ಪರ್ ಲ್ಯಾಮಿನಾ ಇದು ನಾರ್ಮಲ್ ವೇ ಯು ಡೂ ಎ ಲ್ಯಾಮಿನೋಟಮಿ, ನಥಿಂಗ್ ಸ್ಪೆಷಲ್ ಹಿಯರ್. ಬಿ ಪಿ ಎಷ್ಟಿದೆ? ಓಕೆ ಓಕೆ. ಕೆರಿಸನ್ ಕೊಡಮ್ಮ. So this is ಇದು ಬೋನ್ ಎಲ್ಲ ಇಟ್ಕೊಳ್ಳಿ. ಜಸ್ಟ್ ಕೀಪ್ ದ ಬೋನ್ ಎಲ್ಲ ಇಟ್ಕೊಳ್ಳಿ. ಕೊಡಿ RF ಮೋನೋಪೋಲಾರ್ ಕೊಡಿ, ತೊಂದರೆ. Grasper.
Hello.
ಓಕೆ, ಬರ್ ಕೊಡಿ.
Okay. Dr. Anudeep, please. Dr. Darshan CK.
Carry son.
Dr. Ranbir Singh Bawa. Dr. Dhanashekaran.
Grasper. Var.
Dr. Shyam Sundar Krishnan. Dr. Mahendra Singh. Yeah. Next.
ಅದು ಸೇಮ್ ಇದು ಬೋನ್ ಇದು ಇಲ್ಲೇ ಇದೆ ಅಲ್ಲ ಆರ್ ಎಫ್ ಇದೆ ಇಲ್ಲೇ ಇದೆ ಸೇಮ್ ವಿ ಎಫ್ ಎಕ್ಸ್
Dr. Deepak H.G. Dr. Deepak H.G. आपको देना है. Dr. Rohit Kale. Sir, here na.
That is the midline.
Dr. Deepak M.K.
Okay. That is the midline.
Dr. Devai.
Separate ಆಯ್ತು ಇಲ್ಲಿ ನೋಡಿ.
Dr. Fuzelias.
Already separated. Now we'll go here.
Dr. Gaurav. Dr. Gaurav. Yeah. No, he's not the Girish. No, group of Dr. Guru Padappa. Dr. Himesh Babu.
Okay, I'll leave separate ಆಯ್ತು. ಒಂದು ಗ್ರಾಸ್ ಫರ್ ಕೊಡಪ್ಪ. Already there is a osteophyte getting separated.
Dr. Omkar, can I just come on the stage?
थोड़ा बड़ा ग्रास पर है.
Dr. Hari Prasad.
ठीक है. Osteotom, हाँ थोड़ा भर दे दो.
Dr. Hari Prasad, yes. Dr. Hari Prasad. Dr. Karthik.
ಟೇಬಲ್ ಲಾಕ್ ಆಗಿಲ್ವಾ? ಟೇಬಲ್ ಶೇಕ್ ಆಗ್ತಾ ಇದೆ. ಕ್ಯಾರಿಸನ್ ಒಂದ್ಸಲ ಮೊನೋಪೋಲರ್ ಕೊಡಪ್ಪ.
Dr. Lokesh B.S. Dr. Lokesh. Dr. Lingaraju.
Can control bleeding also.
Dr. Lohit.
ಇಲ್ಲೇ ಇದು ಎಪಿಡ್ಯೂರಲ್ ಆರ್ ಎಫ್ ಕೊಡಮ್ಮ.
Dr. Akshay Vijay Kulkarni.
ಪ್ರೆಸ್ ಮಾಡಮ್ಮ. ಆರ್ ಎಫ್ ಪ್ರೆಸ್ ಮಾಡಬೇಕು. ಯು ಟೇಕ್ ದ ಬ್ರದರ್ ಪ್ರೆಸ್ ದ ಆರ್ ಎಫ್. ಫುಡ್ ಸ್ವಿಚ್ is
Yeah, Dr. Janmajay.
Yeah,
Can I come on the stage?
press. So this is the midline, you see.
Dr. Adarsha.
Press, keep pressing. Okay, Carrison. Beda, first give me the osteotome. So I will cut the facet here. This is the junction. Hit, brother.
Dr.
Brother,
Amitava
hit,
Biswas.
hit. And hit. Hit. ಹೊಡೀರಿ ಸಾಕು 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 ಹೊಡೀರಿ ಒಂದು ನಿಮಿಷ ಹಿಟ್ ಒಂದು ನಿಮಿಷ ಹೊಡೀರಿ
Dr. Bhuvaneshwar Minch.
ಸಾಕು ಸಾಕು ಕಟ್ಟಾಯ್ತು ಹೊಡೀರಿ ಸಾಕು So, in the facet, what separated now? Can you see? Grasper kodappa.
Dr. Chandan Dulakasharya.
Grasper. Facet separate ಆಯಿತು. Just hold. Take the bone. Bone ಎಲ್ಲ ಇಟ್ಕೊಳ್ಳಿ. We can at least pack the cage with that. Take.
Dr. Ankit. Yep.
So.
Dr. Chandrasekhar. N. Chandrasekhar.
Take.
Dr. Chetan M.H.
ಏನು ಬ್ರೈಟ್ ಸ್ವಲ್ಪ ಕಡಿಮೆ ಮಾಡ್ಬೋದು. ಗ್ರಾಸ್ಫರ್ ಕೊಡಪ್ಪ. ಇದು ಮೇಲಿದ್ದು ಲೈಟೆಲ್ಲ ಆಫ್ ಮಾಡಿ. ಟಾಪ್ ಲೈಟ್ ಯು ಸ್ವಿಚ್ ಇಟ್ ಆಫ್. ಮೇಲಿದ್ದು ಲೈಟ್ ಆಫ್ ಮಾಡಿ ಬ್ರದರ್.
Dr. Roshan M. Dr. Roshan.
Take. ಓಕೆ ಈಗ ಓಕೆ ಅದು.
Dr. Raghavendra M.S. Dr. Raghavendra Nayak. Dr. Raghavendra Nayak.
No, don't take the contrast. Take.
Dr. Srinivas Murthy.
Okay, this is the entire facet, you see, the facet joint, ascending facet. We have decomposed. This is the tip of SAP. Grasper. Take.
Dr. Srikanth Sundaresh.
ಒಂದು ಸಲ RF ಕೊಡಿ.
Dr. Srikanth
ಇದು
Sundaresh.
lower part, ಇದು upper part.
Dr. Sriram Kati.
ಪ್ರೆಸ್ ಮಾಡಿ ಬ್ರದರ್. ಪ್ರೆಸ್.
Dr. Shravan Kumar B.S.
Stop. Cutter code. So this is the lower lamina, the facet.
Dr. Shrisha T. He had an eventful night yesterday, so still dozing off. Dr. Selvin Prabhakar.
This is the flavum. ಕೆಳಗೆ ಲ್ಯಾಮಿನಾ ಇದೆ. ಕ್ಲೀನ್ ಬ್ರದರ್. Kerison.
Yeah, Dr. Girish Gupta, please. Dr. Satish Kannan.
So this is the facet. So I'll just take it out. I am still keeping all the phlegm inside. This is the lateral facet, means the ascending facet of L5. The descending facet, medial facet we have removed.
Dr. Shreyas Alva.
So this is the tip of SAP, superior articular process. RF code. Just I don't like this design. I don't like this handle. Press. This is the tip of SAP. Can you see?
Dr.
Stop.
Sharad Babu.
Stop. Coding. Carrison. Tip of SAP ಇದು ಕಾಣುತ್ತಾ? Tip of SAP here. Just take it out. Take.
Dr. Shivanand Reddy.
Saline ಖಾಲಿ ಆಯ್ತಾ? ಇಲ್ಲ ಅಲ್ಲ? RF. ಪ್ರೆಸ್ ಮಾಡಿ.
Dr. Tarun Chabra. No. Dr. Vinod V. Rajan. Yeah.
Stop. Carrison. Grasper first and then Carrison. Carrison.
Dr. Vikas Naik.
Nothing happens. Take. Bone ಇಟ್ಕೊಳ್ಳಮ್ಮ.
Dr. Vijay Kumar. Dr. Vijay Kumar.
RF ಕೊಡಮ್ಮ. Just give me RF. There will be some bleeding here.
Dr. Vishnu Kumar.
Under the facet.
Vishnu was not seen yesterday.
Press.
No.
Okay, just control it. Stop. Bar ಕೊಡಪ್ಪ. ಬಾರಲ್ಲಿ ಹೋಗೋಣ, ತೊಂದರೆ ಇಲ್ಲ.
Dr. Vidyasagar.
So we'll go with the burr here.
Dr. Yogesh Kumar.
We'll go with the burr here.
Dr. Avinash GC. Dr. Avinash. Dr. Abhishek Songara.
Oops. Oops, RF. Just press ಮಾಡಪ್ಪ.
Dr. Anshul Taran.
One second. Press. ಸ್ವಲ್ಪ ಪ್ರೆಷರ್ ಕೊಡಿ. Stop. Okay.
Yeah, anyone not received a certificate, please.
Carrison.
Your good name, doctor? Please.
ಒಂದು ನಿಮಿಷ.
Anybody else? Apart from the faculty. Faculty, we are ready to give. Sorry? Sure. Registration will wait for some time. We'll take your address and then post you because it has to be signed by the KMC people. Okay? Yeah, thank you. तरुण चावला जी का इधर ही था, इधर ही पड़े.
Okay. So Carrison again. Carrison.
Dr. Tarun.
ಇದು ಅಪ್ಪರ್ ಲ್ಯಾಮಿನ ಫೈನಲ್ ಪಾರ್ಟ್. ಓಕೆ Hold. Take the bone.
Dr. Shiraz Ahmed Munshi.
It actually 3 mm. 3 mm. ತಗೊಳ್ಳಿ bone. Actually 4, 5 ಎಲ್ಲ ಇದೆ, but today we have only 3 mm. ಅದು ಫ್ಲೇವಮ್ ರಿಲೀಸ್ ಆಯ್ತು ಇಲ್ಲಿ. ಸೊ clean. You just need to clean this bleeding. Just punch it, it will stop.
बैठ जाओ यहाँ. डॉक्टर अंकित.
Burr kodama. Burr. I'll use the burr. Actually ಸಾಕು. ಯಾವುದು?
ಡಾಕ್ಟರ್ ಗಿರೀಶ್ ಗುಪ್ತಾ.
ಯಾವುದು? ಹಾಂ ಹೌದು. ನಾಟ್ ರಿಕ್ವೈರ್ಡ್. ಸುಮ್ಮನೆ ಇಟ್ ಇಸ್ ಎ ಫ್ಯಾನ್ಸಿ ಐಟಮ್. Kerison. No articulation, no protection. Yes. So I didn't know phlegm is fully released. Yeah. Clean.
डॉक्टर आनंद. डॉक्टर जन्मिजय जी.
ಸೊ ಇದು ಕ್ಲಿಯರ್ ಆಯಿತು. ಇದು ರೂಟ್ ನೋಡಿ, ಯಾವುದು ಅದೇ ಡಿಸೈನ್ ಇದು ಯಾವುದು L4 ರೂಟ್ ಅದು. ಹಾಂ L4 ರೂಟ್ ಅದು. ವಿ ಹ್ಯಾವ್ ಗಾನ್ ಅಪ್ ಟು ದ ಪೆಡಿಕಲ್ ದೇರ್. ಸೊ ದಟ್ ಮೀನ್ಸ್ ಅವರ್ ಅಪ್ಪರ್ ಎಕ್ಸ್ಟೆಂಟ್ ಆಫ್ ಡಿಕಂಪ್ರೆಷನ್ ಇಸ್ ಗುಡ್. ಯಾವುದು ಫುಲ್ ಹೋಗಿದೆ ಈಗ ನೋಡಿ.
ಡಾಕ್ಟರ್ ಮಹೇಂದ್ರ
ಬರ್ಕೊಡಿ. So you have achieved a very good decompression here, boniver. Harsha, when you are putting screws here, be careful because I have removed the facet. Okay. Cutter kodappa. So this is the full extent of our decompression. Kerison kodappa. So we will start releasing a phlegm from down. Yeah, we will remove. So let me see where I am. Okay. Kerison.
डॉक्टर मनमीत.
Clean. This is the L5 lamina. Can you see I have released there? You can see the dural sac. Okay. Dural sac ಅಲ್ಲಿ ಕಾಣುತ್ತೆ. RF ಕೊಡಮ್ಮ. ಪ್ರೆಸ್ ಮಾಡು. Brother, press. Okay, 1 second. Yeah, press.
डॉक्टर ओंकार.
Stop. Kerison. Okay. Keep the bone.
Dr. Vishnu,
Keep the bone. Keep
Dr.
all the
Sukumar,
bone. Okay.
Dr. Gururaj, Dr. Shri Harsha,
Harsha is here.
Dr. Sunil H,
So ಇದೆಲ್ಲ ರಿಲೀಸ್ ಆಯಿತು. Okay. So everything is released here now. So only midline cutter kodappa. Cutter. So I'll release the midline now. So this is the midline, you see. So I'll cut here, start cutting here. Nodi, I can see the dura. Clean. So again go here. So the dura is below me. Okay. See. Again go here.
Dr. Ravindra,
Okay. Dura is below me. Can you see? Okay. So clean. And the final part here. Kerrison. Okay. So it is released. Okay. So that side it is released. Top it is released. Only this lateral part also I have to see. I think it is released here also. So give me the grasper now. I think it will come out now. Grasper. This is actually a very flimsy grasper. Still it came because it is released. Not very strong. Grasper. ಸ್ವಲ್ಪ pressure ಕೊಡಿ and little oozing will be there. So where is it? Okay. ಇಲ್ಲ ಅದು blood vessel ಅಷ್ಟೇ. Blood vessel. Okay. We have not touched the dura anywhere, so nothing to worry. There's some bleeding there, that's all. ಸ್ವಲ್ಪ pressure ಕೊಡಿ ಅಷ್ಟೇ. Need to catch this.
Mahisha, we finished with the certificate distribution.
So far
our undivided attention is towards your surgery now.
Okay, so what I have done is I have done a laminotomy and I have done a facetectomy.
Okay.
And now what I am doing is I have released the phleum all around. Now I am picking the phleum up. Okay?
Yeah.
Picking the phleum up and removing it. Actually, our forceps are very small, so it is coming in pieces. But anyway, within a moment we will finish this.
Have you put the screws already?
No, screws Dr. Shiarsha will be putting later.
Okay.
Because we have to manage the time. So we have started both theatres.
Okay.
So Dr. Raghav is already putting the screws on the other side.
Okay.
And here we will be putting the cage first, followed by the screws.
Yeah.
So this is the phleum. She is thick hypertrophied phleum, which we will take it out. It is attached somewhere, little bit down here. Okay, the dura is underneath. So the phlegm has come out now. I can show you both L4, L5 roots here now. Give me RF one. So, can you see the L4 root? Can you see the L4 root? Can you see? Okay, give me the kerosene. Grasper.
Oh, sorry. Mahesh, anything?
Yeah, I was showing you the L4 root.
Oh, okay.
Means
Sorry,
the exiting root.
Oh, I see. Okay.
If your bone work is very good, you can see it. Do you see? See the L4 root here?
I can take no problem. तो काम तो हो गया उनका. So yes, she's done. So you can check in later also. Have
Press ಮಾಡಿ brother.
Oh, fantastic. Very much helpful.
Press. Can you see the L4 root? Hello?
Yeah, yes.
This is the L4 root.
Yeah, yes.
Okay?
Okay.
This is the dural sac.
Yeah.
This is the L5 root.
Okay.
Is the anatomy crystal clear?
Yes, very much.
So I'm just controlling the bleeding now.
Okay.
So.
You are still using the monopolar?
No, monopolar is only for the bone.
Okay.
That stage is over long back.
Yeah.
Okay, this
because
is the
you are using a nerve root, so we thought you were continuing.
Yeah, stop. You see, this is the space for me to go in. Can you see?
Yes, beautiful.
So anatomy is crystal clear. Can you listen?
Yeah. So you're doing endoscopic assisted P-leaf or endoscopic P-leaf.
So I will just do a little bit of over the top decompression here.
Okay.
Then I will go for the disc.
Fine.
Okay. Any doubts?
Any questions? Which RF you are using?
Today I am using Bones RF.
Bonds.
But back home I use RF from Hebar.
Okay.
Press. Actually for me monopolar and RF is more than enough. I don't require plasma. See, any bleeder anywhere you have to coagulate. Otherwise they will keep irritating you.
Yeah.
Kerosene? Big. Yeah. So I will just do over the top here. Okay. पानी का थोड़ा प्रेशर हो सकता है. So other side, Dr. Raghav is already putting the screws.
Okay.
So we will be showing the transforaminal cage that side after we finish this interlaminar cage.
Yeah, oh, it's fine. Sure.
Okay.
Sure.
So we will be showing both techniques.
Okay.
So I am privileged to have Dr. Sriharsha here and Dr. Raghav there, so that we can show both the cases.
Yes.
And they have done my work much less.
There's one more case if you want to operate.
Yeah, but I have to reach Mangalore. Tomorrow I'll be killed if I don't reach today. Actually, the other case, probably I think interlaminar decompression alone will be enough. There is not much of instability, so you can just do a decompression, and I will not do a fusion for her. So this is the over the top decompression. You go between the over the dura and do the decompression. Okay. Actually, when we are doing a good decompression, over the top is not necessary, because when you are doing a misty leaf, you don't do it routinely. Give RF. But anyway, in this case we are doing, because patient had bilateral symptom. Press. Stop. Press. थोड़ा pressure बढ़ाओ. Pressure is not there. Press. So there will be bleeders between the phlegm and the bone, from the bone as well as from the dural surface. So all the three places will ooze. So when you do decompression, okay? Carrison. So we are about to finish this level, this side, contralateral side. So we go, you can see the dural sac, go inside and lift your carrison so that you are away from the neural elements. So slide and cut. Hold. Take. RF. Press. Stop. Carrison. Clean. So always you should have a good hand-eye coordination. You should see what you are catching. Then you will not have complications like dura tear. And you should have a good vision. So if there is bleeding, it will obstruct your vision. So you see, this is the final decompression here. The lateral recess on the opposite side. RF.
Mahesa sir.
Yeah.
You are using 15 degree or the?
This is a 15 degree
15
scope.
degree, okay.
Press. This is a 15 degree, 8.4 mm outer diameter, 5.7 working channel scope. This is a very good scope actually.
Okay, sir.
Stop. Carrison. You can see the opposite lateral recess now. So I will finish the final part here. So if there is a bone bleeding, just go inside and punch that bone with the carrison, it will stop. RF, can you see the opposite route?
Yes, sir.
It is fully decompressed.
Very appreciable.
Yeah. Press. Okay, stop. So I will show you in a moment. Okay. Can you see the opposite route?
Yes, sir. Very
Crystal
clear. Very clear.
Okay, this is the dural sac. This is the L5 route on this side. This is the L4 route on the same side. This is the exiting route, and this is the disc. Now, once you do a facetectomy, you can use this cannula to retract the neural elements. You see, there is enough space. Give that bevel, that annulotome. So now I am going to do is, brother, press me the RF. I will enter the disc now and do discectomy. Press. So some bleeders are there, just coagulate. Stop. And there is not much of retraction of neural elements here. Okay. So go inside and retract. Yeah, give me the annulotome. So this is the annulotome. I will just enter the disc here. Okay. This is a very good instrument to make the initial entry into the disc. और मुझे एक cutter भी चाहिए. Actually, if you have a good osteotome, it will be very good. But unfortunately, we don't have it here right now. Saline, get the saline on, please. Hold. Give. So the disc is lordotic and the entry is narrow, but anteriorly it is quite wide. Okay. So I am just cutting this disc with the annulotome. This is a very good instrument. Okay.
Yes, sir.
So I am just cutting the disc and give me a grasper, brother. So this is the exiting route here. Okay. Give me the grasper. The dura is there. I have to retract the root. Okay, grasper. So this is the disc. Clean. 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 Cutter दे दो एक बार cutter. So any questions?
No, it's fine, Mahisha, we're all watching.
Okay. My brain is programmed so that if there is no stimulation, it goes on silent mode.
Yeah, you know.
I am not like Sukumar.
Yeah.
Sukumar is continuously on.
Yes.
I am continuously off.
Yeah, because you're more focused on the job. So,
Yeah.
yes.
Grasper. Sukumar can give running commentary for 3-4 hours. But unfortunately I cannot. Can you see the disc face now?
Yeah, yes.
So it is clear.
I can make out, yeah.
Yeah. And today we have absolute bloodless field.
Oh, fantastic.
So I don't know how it is seen there, but here it is excellent.
No, it is very clear, very clear.
I am extremely happy with the field today.
We are getting old, but then our vision is still holding on. So what you see clear, we also see clear.
So now what I do is, you see, can you focus here? So I need a CM, get the CM technician here. So to make the matters easy, I will take out the scope, okay?
Yeah.
See, my cannula is retracting the neural elements. Hold this. So get me a lateral view. Udhar rakh do. So I am just holding the cannula and get me the dilator. So I will go inside with the dilator, okay?
Okay.
So this will distract the space.
Yeah.
Lateral view.
So your cannula is retracting the exiting route.
Yeah. So this you have to do under image. Lateral डालो. ये क्या है थोड़ा ऊपर हो सकता है हाथ ಅದನ್ನು ನೋಡ್ಕೊಳ್ಳಿ ಇದು ಆ ಕಡೆ ಇಟ್ಕೊಳ್ಳಿ ಮುಟ್ಟಬೇಡಿ ಆ ಕಡೆ ಹೋಗಲಿ ಹಾಂ ಗೆಟ್ ಮಿ ಎ ಲ್ಯಾಟ್ರಲ್ ವ್ಯೂ ಒಂದು ಆರ್ಟ್ರಿ ಕೊಡಮ್ಮ ಹಾಂ ಈ ಕಡೆ ಬರಲಿ ಸಿ ಎಮ್ ಬಿಡಿ ಡೋಂಟ್ ಟಚ್ ದಟ್ ಡೋಂಟ್ ಟಚ್ ದಟ್ ಒಂದು ಹ್ಯಾಮರ್ ಕೊಡಮ್ಮ ಹ್ಯಾಮರ್ So I've just hammered the dilator inside. Sure. So I'm just going inside with the dilator. Sure. No. Shoot. Okay, it has gone inside.
Yes, yes.
Now give me the that black thing to push it in. So now I'll push the cannula inside. Okay.
Okay.
Just to speed up the things. Okay.
Yeah.
So what this will do is it will distract the disk space.
Yeah.
Sure. Okay.
Cannula is how much mm?
Cannula is 9.5 mm. Sure. Okay.
Yeah.
So my cannula is inside. You can see that the disk is distracted.
Yes.
Now I'll use curettes to do a manual discectomy.
Okay.
Okay. First I will use this big curette.
What will be the size
And
of
give me the grasper.
cage you are planning to insert?
Maybe 11 mm.
Okay.
Leave it. Sure. Brother, don't touch anything there. So this is a normal curette. So, sure. Okay.
Yeah.
So I'll just go inside. I can go with feel.
Okay. But then you will remove the disc material under vision?
No,
afterwards?
initially I will do under C-arm, sure. Then I will remove under vision. I'll put the scope again and remove under. I am going between the end plate and the disc.
Okay.
Sure. Now I am going to the lower end plate. Can you see?
Yeah.
I am grazing the lower end plate
Yes.
and separating it from the bone. Sure. Clean. Give me that two reamers. Jayan, 8 का दे दो, बड़ा वाला. 8. Don't touch this. Sure. So this is a reamer from Jayan only.
Okay.
So it goes inside. Sure. This is a 8 mm reamer. Sure. Okay.
Yeah.
So it has gone inside. Give me a grasper, big grasper. इसमें है. I have taken it out. Work long grasper. Normal disc forceps ಇದೆಲ್ಲ. ತೆಗ್ದಿಟ್ಟಿದ್ದೆ. Normal. ಅದಲ್ಲ. Normal regular disc forceps. ಇಲ್ಲಿ ತೆಗ್. ಅದರಲ್ಲ ಇದರಲ್ಲೇ ಇತ್ತು, ಎರಡಿತ್ತಮ್ಮ. ಇಲ್ಲಿದೆ ನೋಡಿ. So I can use a normal disc forceps which is little long to remove the disc material. Sure. Okay.
Yeah.
So you see? Can you see the disc?
Yes.
Okay.
Yeah.
So you can remove big chunks with this, because with the endoscope, don't touch anything here. Endoscope, it will take long time. Again, curate.
Mahesa sir.
Yeah.
How you make your confirmation that your retracted root with the cannula is not displacing, means not slipping out?
No, cannula is inside, you see.
No, cannula is inside, but it is not rotating there?
It's not rotating, it is fixed, you see.
Oh, yes, you have already entered in the disc space. Okay.
Don't shoot. Okay, shoot. So can you see I have reached the anterior part?
Yeah.
Clean. So next I will do is I will use one more instrument. So I will use this instrument to do some more reaming. This is the instrument which opens up like this, and I tighten it, opens up, and I loosen it, closes. Okay? So this is about 11 mm when it's open. Sure? Okay?
Yeah.
Now I am tightening it. You see inside what is happening. Sure? Okay, it is opened. Still I have to open some more. Sure? 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 Give me the other one, similar one. Give me a grasper, this forceps kodama.
The idea of
Sure. Yeah.
including all forms of endoscopy in this conference is basically to give awareness to all newcomers, and of course little more advanced work for people already doing endoscopy. But in future we plan to do this in a different way, where we have two sort of batches where the beginners are taught something else and the people already doing are taught something else. So people already doing they want to see more live surgeries, and they want
Sure.
more practical tips. So I believe for them teaching something basic is a waste of time. So whereas for the beginners, if you show all this, they get confused. So it's better they start with the basic topics, and so maybe the next conference we plan that way, where we have two different batches in two different rooms and two different faculty, and sort of a basic and advanced course together.
Okay.
So they can have the banquet together.
Can you see I can ream this?
Yeah, yes.
Inside? Sure? Okay. This is a very simple instrument. Grasper. Basically, you want to reduce the work with the endoscope. You see, the material came. Yes, light off करो, of course नहीं तो scope खराब होता है. Okay, clean. Clean. A lot of disc to be removed here.
Yeah, Mahesha, there is a question from Dr. Shastri here.
Yeah.
Like, are you using bone grafts also, or just only cages? I mean,
No.
Instead of cages, have you attempted with just using bone grafts?
No, you can use only bone graft.
Yeah.
But there is risk of collapse and failure of the screws. It will unite, but the implants will fail because there is no structural support anteriorly. I have done many cases without cage, but some of them will fail.
Okay.
Sure. Can you see the disc space is clean now?
Yes, yes.
Okay, you can make out that it is, you can see the air shadow inside. That means we have done a good decompression. Remove the CM. Brother, remove the CM. Now we will put the scope inside. Okay?
Yeah.
Remove. Give me a mop, something. ಇದು ಕೇಜ್ ಒಂದು ಲೋಡ್ ಮಾಡ್ತೀರಾ 11 into 25. Light on ಮಾಡಿ. So now we'll put the scope for final clearance. Table fully down, please. Light on here. This on. So now we can see the endoscopy picture here.
Yeah.
Okay, we are in the disk space.
Yeah, it's little losing, so picture is little hazy.
It's okay, no problem. Grasper, give me a grasper. So grasper. Can you give some pressure? So we are inside the disk space. Bevel is facing laterally currently. I'll turn it medial. Okay, just come out a bit to see where the root is. Okay, the whole thing is the disk space. Okay, give me a curate. क्यूरेट है आपके पास? मेरा सेट में है, दे दो. गिव मी ग्रास्पर फर्स्ट एंड गिव मी द क्यूरेट्स. Curate. We don't have big curates here, so we have to use the small curates. You can see that most of the disk space is prepared. Only fly
The cage, I believe, was designed by Mahesh himself.
No, no, no.
Jayan.
This is a normal P-leaf cage, okay?
Is it? You're not using expandable one?
No, no, no. I don't think we have expandable cage here, do we?
You had made some design for Jayan?
Yeah, but we didn't get it here.
Yeah, design. But
So we will be using a normal P-leaf cage, 11 mm. 25 mm is the depth. You see, I can prepare the end spit, which is already prepared, but we need to do some final clearance for the cage to go in, that's all.
Okay.
Can you see the end plate? Very well prepared.
Yeah, yeah.
And there is no damage to the end plate, grasper. Though we have used some heavy artillery inside. Clean, curate. If you have a bigger curate, it would have much better, but today we have to use a normal small curate. Cutter hai ek paas. So by tilting the cannula, we can clear more and more of the disc. If you tilt medially, you can clear the lateral part, which I am doing now. If you tilt laterally, you can clear the more medial part, okay?
Okay.
Grasper.
Now, your experience with putting a trans-canopin cage and interlaminar cage, so
Yeah.
which you feel more comfortable and...
No, trans-cambion cage is very fast and very easy.
yeah, and position also is better than compared to P-leaf?
No, P-leaf cage also, this position of the cage, both cages, it is good, no issues. But advantage of trans-cambion is very fast. You can see the next case, it will take half of the time. But the problem is it cannot achieve central decompression.
Okay.
So central means, I mean medial and lateral part of the phloem, because I don't want to be controversial here.
Yeah.
So we are not talking about central part of the phloem.
Hmm.
Okay, curate. We need to clear the lateral recess on both sides.
Yeah.
Which is not possible with the trans-cambion cage. So this is possible only with the interlaminar approach.
So how you choose your cases?
Yeah, if I need to decompress, I will go interlaminar.
Okay.
If I don't have to do decompression, I will go trans-cambion.
Okay.
It's very simple. Okay, this is the anterior part of the annulus, grasper. Yeah, we can check. Right now I am just crossing the midline. By the tilt I can make out. You don't have to take exact C-arm. Can you see the anterior annular fibers?
Yeah.
In a moment I will show you. Okay. The anterior annulus has very distinctive orientation of fibers. Can you see?
Yes, yes.
Okay.
Yeah.
You don't have to check C-arm. It is anterior annulus. So our graft will go and sit there. Cutter ek baar. How many of you see anterior annulus when you do TLIF? Or miss TLIF, whatever? So this annulus has 3 layers. Clinically, of course, if you see the anatomy, it has more than 30 layers. But clinically, you can peel off 2-3 layers before you hit the anterior structures, curate. So 1 layer and all, you can take it out, not an issue. Okay. So grasper. Can you see the anterior annulus?
Yes, 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 very much.
Okay.
Yeah.
Nowhere they will show you like this. Okay.
Yeah.
RF. RF. Thoda pressure, press.
So preparation of the space takes more time with endoscopic than with open.
Stop, grasper. Okay, pass curate hai. So this is very well prepared now.
Yeah.
Harsha, you want to see a AP? How much I have gone on the other side? So Dr. Harsha wants to take a C-arm. So we will show that. Grasper. I'll just take out this. 1 minute, 1 minute, 1 minute, 1 minute, 1 minute. So give me a curate. So I'll just put my curate in, and this is my extent of the other side. I can go even more lateral if required, but I think this is good enough. So I'll just keep my curate here. Can you get a C-arm? So I am not exposing myself. Okay, I am staying away from the field. ಈಚೆ ಬನ್ನಿ, ಈಚೆ ಬನ್ನಿ, ಈಚೆ ಬನ್ನಿ. ಈ ಕಡೆ ತೊಂದರೆ ಅಲ್ಲ. ಇಲ್ಲ, ಅದು ನಮಗೆ ಇಲ್ಲಿವರೆಗೆ ಬರಬೇಕಂತ ಇಲ್ಲ. ಬಿಕಾಸ್ ಈ ಕಡೆ ಬನ್ನಿ. ಕಮ್ ದಿಸ್ ಸೈಡ್. ಕಮ್ 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 ಕಮ್. ಓಕೆ, ಕಮ್ ಇನ್ಸೈಡ್. ಕಮ್. ಹಾಂ, ಸಾಕು, ಶೂಟ್ ಮಾಡಿ. ಯು ಜಸ್ಟ್ ವಾಂಟ್ ಟು ಚೆಕ್. Okay. Can you see it has gone to the medial pedicle line on the other side? Out.
We cannot see the X-ray
yeah,
image.
they will show you in a minute. Take it out. See them out. They will show you in a minute. Okay. Take it out. See them out, please. So this is the advantage of endoscope. Means you can go this side and that side with just a 8 millimeter retraction. Okay.
Okay.
Now when I come out, I can show you the dura. Okay. I'll just come out here. Sorry. So this is the dura. Can you see?
Yes, yes. Yeah.
So
yeah, very much.
I just retract it here. Give me a cutter. I'll just make the opening a little bigger. so that the cage will pass easily. So I'll cut some annulus here. ये आपका है थोड़ा क्या हुआ इसका that side case is over. He has come here or he's still there? Okay. Okay, curate. Cutter. So you can see the very well prepared space here. Can you appreciate?
Yes.
Okay. So what I am doing now is I am just making the opening for the cage to a little bigger so that cage will pass easily. The exiting route is retracted by my cannula.
Okay.
Okay. So this is how it is. The dura is here. So cutter. I will prepare a little more laterally here for the cage to go in. So that the cage will be more medial and it will go easily. So I am planning to put 11 mm into 25 mm cage. That is my size here. Can you see the anterior annulus from distance itself?
Yeah.
Curate. So this is the beauty of preparation with the endoscope. You get the best end plate preparation with endoscope. Grasper. Curate. So if you want to go more medial, you can still go more medial, starting from top itself. Grasper. Clean. So that is a well prepared end plate, curate, with the annulus visualized in the front. Okay. Grasper. So it's already one. Okay. So the dura is here. Can you see?
Yes, yeah.
So what I do is focus here. Can you focus here? Give me that knife light on Madi, knife code, and give that retractor, brother. That big retractor is done no, for the root. So first I make the cut little bigger for the cage to pass. Second I will put this retractor, which is a half sleeve retractor, which goes by the side of the cannula. Okay. So you can see the cannula here. Okay.
Yeah.
So see the endoscopy picture. Can you see?
Yes, yes.
Can you see my retractor?
Yeah, yeah, we can.
Okay. So it is there inside. Now
Okay.
I will take out the scope. So my retractor is protecting the neural elements. Give me the lateral view. Hammer. CM lateral view. As long as this is inside the disk space, the roots are safe. Okay. Lateral ಹಾಕಿ. And get me the graft. Cage ready ಮಾಡಿದ್ರಾ? Cage fill ಮಾಡಿದ್ರಾ? Okay. Can you give some G-bone for me? One or two granules. Give me a fresh pair of gloves. Glove ಕೊಡಿ.
It's mainly for the dura. Mahesha.
Yeah.
Now, how are you going to take care of the exiting route?
Exiting route is far away. It is nowhere in the picture.
So you're not bothered about it while
Yeah,
putting the
I'm
cage?
not bothered about it. Okay. Because if you see the opening which I made in the annulus,
Yeah.
the root is nowhere in the picture.
Okay.
And see, we are putting a transcamin cage without protecting the exiting root.
Sure, sure, yes, yes.
This is far more medial.
Yeah.
So you don't bother about exiting root here. Okay. Shoot. We are bothered only about. Can you see the retractor inside?
Yeah, yeah, yes, very much.
So
yes.
as long as this retractor is there,
Yeah.
dura is safe. I'm not bothered. Okay. Dr. Raghav, udhar finish hua hai? Or anyway, this is shown on YouTube, no? So we will mix some G-bone and autograft and put the cage in. Okay. Nibbler kodama. Nibbler. ಇದರಿಂದ ಬೋನ್ ಪೀಸ್ ಮಾತ್ರ ತೆಗೆದು ಇದಕ್ಕೆ ಹಾಕಿ G-bone ಅಲ್ಲ ಬೋನ್ ಪೀಸ್ ಇದಕ್ಕೆ ಹಾಕಿ ಬೋನ್ ಪೀಸ್ ಇದೆ ನೋಡಿ ಅಲ್ಲಲ್ಲ ಇದರಲ್ಲಿ ಒಂದೆರಡು ಬೋನ್ ಪೀಸ್ ಮಾತ್ರ ಒಂದು. So we are mixing some autograft and G-bone and packing it inside, and then we will put the cage. And give me the graft punch. So everything is clear?
Yeah, very much clear.
Yeah.
Yeah. No, the
Graft punch.
cannula is not in the disk space, right? Only the sleeve is in the disk space.
No, even the cannula has gone inside.
It's gone inside?
Yeah. Anyway, even if the cannula is outside, it doesn't matter.
So now what could be the distraction now? How much?
Distraction, I am putting 11 mm.
The sleeve accounts to how much?
Sleeve is about 12 mm. Sure? Can you see?
Yeah.
Graft going in? Sure? So it is going to the anterior annulus. Sure? Till the anterior annulus it will go. Okay. So this is G-bone mixed with the autograft. Punch. Sure. Sure. I think that's enough. Give me the cage. Sure. Now only the retractor is there.
Yeah.
I have removed the cannula. This is my cage. This is a 11 into 25 mm cage which I am going to put here.
Okay.
So it goes here. Sure. Actually, you can see the cage there. Focus on the CM. Okay.
Yeah.
Sure.
Show the CM picture for us. That will work.
Yeah, it is just entering.
Yeah.
So, brother hinget kodle. Just hold like this. Here, like that. Okay. I am going inside. Leave. Sure. So it has entered.
Yeah.
Okay. Sure. So this is what you have to do, because sometimes when the cage goes inside, it will push the
sleeve
dissector
out.
out. So I have
Yes,
just
yes.
pushed it again inside. Sure. Okay, it's gone inside.
Yeah.
Sure. Okay.
Yes.
So, sure. Okay.
Yeah.
So I'm happy with the position. Okay, I will take it out. Remove, brother. Give me the cannula. Okay. Now shoot again. Okay.
Yeah.
So it's a big cage.
Okay.
It is inside.
Yes, yes.
Okay. Now I put the cannula inside again. Give me the scope. So you can see that my retractor is still in place.
Yes, yes.
Okay. Light, can you switch off the light? So,
Now, what is the purpose of that? I think the sleeve can come out, no?
yeah, I wanted to show you. It can come out. Grasper. So, are you happy with the size of the cage?
Yeah, very much, very much. It's fitting very snugly.
Yeah, it will not come out. Now only Dr. Sriharsha has to be careful while putting the screws. Saline barta ilva? Just a ಸ್ವಲ್ಪ flow barli. Okay, give me grasper. Pressure ಸ್ವಲ್ಪ ಕೊಡಿ. You have any more talks left? Can you see the cage in the endoscopy picture? Can you see the cage? Hello?
Yeah, yes.
You can see the retractor. Can you see the retractor?
Yeah,
At
of course, yes.
12 o'clock position. See,
Yeah.
this is my retractor.
Yeah.
Brother, pull it out. So my brother is taking it out. You see the pull. Nikal do. See, the dura has come in the picture now. Can you see? Okay. Is everybody clear?
Yes, that's clear.
Okay. Give me a dissector. See, the exiting route is somewhere here. Now there is some blood. So some G-bone particles are there. Okay. The exiting route is here. This is the exiting route. Okay.
Yeah.
You see the gap between the end plate
Yes.
and the exiting route. So
Yeah.
that's why I don't bother about the exiting route.
Okay.
I am worried only about the traversing route. Grasper.
Fine.
So everybody is convinced?
Yes, very much.
Okay, dissector. So it is below the end plate on both sides. Because it is a 25 mm cage, it will be a little close to the posterior. This is the end plate, this is the cage. So there is about 5 mm of bone between the posterior border of the body and the cage. Okay.
Yeah.
So now this is the dural sac, which is very well protected during the surgery.
Yes.
Okay. The exiting route is here. I will show you the exiting route. See the exiting route?
Yeah.
Exiting route is here.
Yes.
Very well protected. Dural sac is here. The dural sac is fully decompressed. Dissector. Some blood clots are there. We'll take it out. Okay. Grasper. So anybody in the hall or only organizers are there?
No. Plenty of them are there. They
Okay.
are mesmerized by your surgery, so they are not moving.
So everybody clear?
Yeah,
So
very
I'll
much.
not remove the blood clot from the other side because it is waste of time.
For you to make out, we'll give you a big clap now.
Okay, thank you. Thank you all. You see the route, very well protected, cage, dura, excellent decompression. Now Dr. Sriharsha will do another excellent job of fixing it.
Sure.
Thank you all. We will, in another 5-10 minutes, we will be on the other side.
Okay.
We will show the transcamin cage.
Okay, that's fine.
Okay, see I'm out. One API.
Yeah, even though the technique is the same for what you do for PLEAF, so visualization and delineation of structures is so good that you avoid some errors, some complications.
Give me a fresh glove.
Maybe it might take a little more time because when you remove the disc, the grasper is quite small, whereas with a disc force up, the regular disc open, this thing can do a job quicker.
ನನಗೆ ಗ್ಲವ್ ಒಂದು ಕೊಡಿ, ನಾನು ಈ ಇನ್ಸ್ಟ್ರೂಮೆಂಟ್ ಆ ಕಡೆ ಕೊಂಡು ಹೋಗ್ತೇನೆ. ಇದನ್ನು ಇದನ್ನು ವಾಶ್ ಮಾಡಿ ನನಗೆ ಸೊಲ್ಯೂಷನಲ್ಲಿ ಹಾಕಬೇಕು. ಓಕೆ, ನಂದು ಸ್ಕೋಪ್ ಒಂದು ಸೊಲ್ಯೂಷನ್ಗೆ ಹಾಕಬೇಕು. ಹಾಂ, ಸ್ಕೋಪ್ ಒಂದು ಸೊಲ್ಯೂಷನ್ಗೆ ಹಾಕಬೇಕು. ಹಾಂ ಹಾಂ, ಬೇಕಾ? ಎಲ್ಲಿ ನಿಮಗೆ ಬೇಕಾ? ಅಲ್ಲ, ಇದು ಬ್ಲಂಟ್ ನಿಮ್ಮ ಒಂದು ಸಾಕಾ?
Mahisha,
Yeah.
what we'll do is we'll see Sriharsha putting the screws, couple of screws, and then in the meantime, if you are ready on the other side, then we'll go to the other side.
Yeah.
That completes the entire job, so then we can move for
Dr.
lunch.
Harsha will show you the screws now.
Yes.
Okay, because it will take another 30 minutes for me to get ready there.
Fine. Okay.
Yeah. Open it.
ಮುಂದೆ ಬಾ. Good. ಅಲ್ಲಿ ಹುಷಾರು. Am I audible? Hello, check. Am I audible there?
Yes, Harsha. Yeah, you're very much audible.
Yeah, we're just removing all the endoscopy instruments. We just. Can you focus on the Siam? One camera on the Siam. ನಂದು ಫ್ರೆಶ್ ಮಾಪ್ ಕೊಡಪ್ಪ. ಸಕ್ಷನ್ ಕನೆಕ್ಟ್ ಆಗಿಲ್ಲ ಅವನು. Can you see the Siam image?
Yeah, yes, of course.
So before you start, the most important thing is to make sure that the patient is positioned properly.
Yeah.
So patient body should be parallel to the ground, so that when you look at the Siam, the interpedicular distance should be equal in the top and bottom. There should not be any tilt. So before you start the case, you make sure that patient is absolutely parallel to the ground, and if required, you can tilt the table to make sure that the pedicles are parallel to each other.
Okay. Now that cage is going to interfere with your imaging?
No, the cage is in absolutely fantastic position. It's almost in the midline, so it will not come in the way at all.
Okay.
Shoot. So I use a forceps to mark the pedicle. Shoot. Shoot. Okay, now the forceps is on the lateral edge of the pedicles, both top and the bottom. So my entry point for the incision would be lateral to that, because we'll be angulating the screws medially. We'll try to enter the skin, have the skin incision lateral to the pedicle. So the incision would be in between the two limbs of the forceps.
Okay.
Right?
The cage, it is in the midline.
I told him just now. Mahesh wants to reiterate that cage is in excellent position again.
Yeah. It's already confirmed by you.
Knife. So here we'll be using one single incision to put two screws. So the incision probably would be around 2 centimeters or 2.25 centimeters. So I'll make sure the tip of the forceps is where my incision ends. So I have to make sure that I'm comfortably able to put screw in the L5. So once the skin is inside, I also go down and incise the fascia.
Okay.
And put a finger to just get a plane in between this thing. Either you can do it using a tip of your finger, or you can use a artery to do it. So now I'm able to feel facet of both L4 and L5. Needle. So this gentle dissection will make sure that when you're putting the screw or when you're tapping, the muzzle doesn't get caught in the tap on the mop. So this is the side where the decompression has already been done. So I have to be careful because there is a gap there. I shouldn't go in between. So I should be very, very gentle. Should. 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 One second. Should. 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 So this is where I would want to enter. It's about roughly 11 o'clock position on the pedicle. If I just go above, I can feel the place where the Mahesh has already done the osteotomy. So I can't go above that. So I'll try to start from there. Should? Malin? Yeah. Yeah, that's what I was telling them. So, should? Yeah, I'm going then. Just go ahead. Yeah. Should? So this is where the edge of the osteotomy side should? Okay. Should? 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 Almost the entire facet has been, most of it has been taken out, so it's difficult to get a starting point there. Should? Should? No, this is what I should. Yeah. The edge is there. Should? Yeah, this is the edge actually. So it's a little bit. Yeah. Should? Superior latus. Should? Should? This yam is not very, the clarity is not very good, so but I would not cross the medial pedicle line until I see the lateral view. So you can see the angulation is there compensating for the lordosis at the L5. L4 would go more straight. Should? 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 Good. Yeah? Yeah. Should? Yeah, knife. So we'll do the same on the other side too. Mop. Shoot. Shoot. Yeah, nice. Shoot. 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 Yeah, that's exactly where I would want to start, at 1 o'clock position here. Shoot. Shoot. Yep. So I'm just stopping short of the medial pedicular line until I see the lateral view. Shoot. Shoot. Yeah. Shoot. 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 Yep. Shoot. 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 Punta. Shoot. Shoot. Yeah, this I'm not very happy with this. Let's just. Shoot. Shoot. I think I'm a bit distal. Let's see the lateral view. Second. ಏನಪ್ಪ ಇಲ್ವಾ ಇದೇ ತಗೊಂಬಿಡಿಲ್ಲ ಏನೇನು ಹೈಟ್ ಕಮ್ಮಿ ಮಾಡೋ So as you can see, the one on the L5, because the facet was not there, went distally. So I need to adjust it. Others look fine. Should. AP. Should. I think. Should. Should. Yeah. I think this will be okay. If you can see, I'm using two different kind of needles. These two belong to the Medtronic set, and these two are from my kyphoplasty set. So wherever I get these jump setting needles, I save them, get them ETO'd, and use it for the next case. So try to cut costs wherever possible. Okay. ಆವಾಗ ಸ್ವಲ್ಪ ಡಿಜಿಟಲ್ ಇತ್ತು, ಈಗ ಸರಿ. ಗೈಡ್ ರೆಡಿ ಇರಪ್ಪ, ಯಾರು ಸ್ಕಬ್ ಮಾಡಲಿಲ್ಲ. Yeah, I think we're in, all the four needles are in good position, so we'll start putting the guide wire and the tap. So this is a guide wire. I normally use only a blunt tip guide wire, not the sharp one, especially in elderly ladies, because sharp ones, even with slight pressure, it tends to sink into the bone, and sometimes, if you're unlucky, you might end up in the abdomen. Should. So, Idipa. So this is a cannulated tap which I've got now. When we started off, we didn't have the cannulated tap, and we had used orthopedic general trauma tap, but this is one which I got from Medtronic, so it makes things a little bit easier. So since the guide wire is inside, I need not take multiple shots. I'll just take once just to see if I've reached enough depth. Should. Should. Screw ready, yeah? So this side we are using a non-cannulated screw now, so the guide wire and the tap both can come out. Now the challenge is to negotiate the screw into that hole.
So okay.
This is the tricky part. You can see the guide wire with the tap is out. Guide wire is also out. So this can be sometimes very easy, sometimes can be frustrating. They usually can tried to fill the hole. Should. Uh-oh, yeah, heavy down. Should. Okay. Mosquito. Should. So now we are in the hole. This time we got it fairly easily. So usually on the side which you are not decompressed, since there is no big cavity, usually it goes easily. So basically I can feel that it's biting the bone. If you want to confirm, all that you have to do is you try to push it on that side. If it's not moving freely, that means you're inside the bone. Should. Okay, that's the depth you wanted. Get where? Tap. Screw it here.
Screw size?
It's 6.5 into 45.
45.
50. Yeah.
50.
50, 50. Sorry.
Okay.
Should. If it's a cannulated screw, then we don't have to tap it this much just to make the entry. But since this is not cannulated, so you need a little bit larger hole for the screw to go initially. So that's why I'm tapping it more.
Yeah.
Otherwise, just tapping up to the pedicle is enough.
Yes, more than enough, yes.
You can't remove without keeping the guide wire, right?
Sorry?
You can't remove this without keeping the guide wire.
I can, but there's no point. Anyway, it has to come out. If it's a cannulated screw, I'll leave that guide wire behind, and the screw goes over it. So here what I found out is the gap between you taking out the tap and putting the screw should be minimal. It would have created a gap, so it's easy to just follow that. If you give more space, the muscles will cover and you have to struggle a bit. So usually I keep the screws ready. Should. So that's about it. You don't, most of the times if you know, you don't struggle, but sometimes you can get stuck. Should. That should be enough. You need one assistant to hold the guide wire so that it doesn't come out. If it comes out, then you have to start over all again. So somebody to hold the guide wire is very important when you're taking out this needle. This is Medtronics, that's why it's good. Should. So this side, since we are dealing with facet which has been osteotomized, things a little bit are tricky here because it slides onto the other side. It won't go into the hole, but we'll see if we can get it as fast as possible. Ready? Shoot. Yeah, I think we got it this time too. Make sure the skin is not getting caught underneath. Yeah. Shoot. Should. But always keep a watch on the guide wire. You can see the guide wire is moved along with the tap. Since it's osteoporotic bone, if you don't look at it, sometimes the tap can just push the guide wire into it. So if the guide wire is also rotating with your tap, then it means the guide wire is advancing forward. So you need to stop and retract the guide wire a bit. Ready, screw? Kaiಗೆ ಇಟ್ಕೋಬೇಕು. Shoot. Okay. So no problems here also. So we have all the 4 screws. If the screw is going inside too easily or it's too much wobbly, then you're outside. Should. Should. Okay. So if you can appreciate, you can see the flange of the reduction screw is almost at the level of the skin. So there'll be no problem in putting the rod inside. You can appreciate here. Usually L5 and S1, it's not a problem because it's lordotic. It will come into the skin, out of the skin easily. So we'll measure the AP. We'll see the AP, measure the rod and put the rod. Sakala. Should be okay. So, AP position, all the screws look satisfactory. Any comments?
No, all good, all good. Yeah, perfect.
I think it though. So, take out. Out, see I'm out. ಇದು ಎಷ್ಟಿತ್ತು ಇದು ಬೇರೆ ಸೈಜ್ ಕೊಟ್ಟಿದ್ರ ಅಂತ ತುಂಬ ಉದ್ದ ಇದೆ ಇದು ತುಂಬ ಎತ್ತರ ಇದೆ ಇದು I think one of the screws is slightly bigger in size. I'll just try to change it.
Okay.
Same incision? No, different. Yeah, you can, if you want, you can put. ಎಲ್ಲನೂ ಅಷ್ಟೇ ಕೊಟ್ಟಿದ್ದ 45 ಕೊಡಿ ನಾನು ನಿಮ್ಗೆ ಫಸ್ಟ್ ಹೇಳಿದ್ದು 45 ಅಂತಾನೆ 45 ಅಲ್ಲ ಇದು about a lateral twist. So once we take it out, again it's come. ಅದು ತುಂಬ ಉದ್ದ ಇದೆ ಇಷ್ಟು
ಸರ್ ಇದೊಂದು ಗಾಸ್ ಪೀಸ್ ಇಟ್ಕೊಂಡು ಸರ್ ಅಷ್ಟೇ ಫಿಕ್ಸ್ ಮಾಡಿಕೊಳ್ಳಿ ಒಂದು ಸಿಯಾಮ್ ಎ ಪಿ ಬರಲಿ ಸೆಕೆಂಡ್ ಗ್ಲೌ ಕೊಡಿ ಇದು ಪುಟ್ಟಿಂಗ್ 30 mm ಕೇಜ್ 7 8
Mahisha?
Yeah.
You are in the other OT, right?
What?
You are in the other OT?
Yeah, I am ready.
Okay, fine.
Once you are ready, you tell me, I will start here.
Yeah, we are ready. I mean, we are seeing both the screens. We are seeing Sri Harsha also operating, and we are seeing you also operating.
I think Mahisha can start. For me,
yeah,
it's only
start,
putting the rod. So
I am just waiting for Harsha to finish because once he clears, I will start.
Yeah.
No, you can carry on. I
you
won't
can
be
carry on.
talking much.
We are seeing you both, so not a problem.
Okay.
Yeah.
So then I will start here. I will just get things ready and we will start.
Cable down, rod.
11,
Screws ಎಲ್ಲ ರೆಡಿ ಇಟ್ಕೊಳ್ಳಿ
ಯಾವುದು
ನಾನು ಕರಿಬೇಕಿತ್ತು ಕಣಪ್ಪ ರಿಸ್ಟಾರ್ಟ್ ಮಾಡೋಕ್ಕೆ
ಹಾಂ ಓಕೆ ತೊಂದರೆ ಇಲ್ಲ 8
section
8 9 10 11 12 okay with the handle. So give me the marker pen. One lateral hakappa. Put lateral. Table up please. Lateral. Yeah. So table up and lateral.
ಸಣ್ಣ ಲಂಗನ್ ಬೇಕು.
So we are taking a lateral view just to know the inclination. So we have to be parallel to the lower end plate. Sure.
So if you can hear me, you can see me inserting the rod into the reduction screws.
Sure.
Yes.
And that's as easy as that.
Sure.
Screw.
Okay. Marker pen.
This rod holder will control the rotation, so I will not let this go till the
Okay.
screws are tightened.
ಇಲ್ಲಿ ಮುಟ್ಬೇಡಿ ಬ್ರದರ್. AP ಹಾಕ್ಕೊಳ್ಳಿ. AP. ನೀಡಲ್ ಕೊಡಿ. Okay, sure.
Yeah, on Siam picture, okay, is marking. Mahisha, your side, the screws have already been put, isn't it?
Yeah,
Yeah,
Dr. Raghav has already put the screws
Yeah.
just to save the time, because
Yes, yes.
otherwise we will not be able to manage the logistics here.
Yeah, and you cannot catch your bus also.
Yeah. So that is the only reason we are doing like this. It has helped us to save time and also for you to see both the
Yes, yes.
techniques
Yeah.
together.
Yes.
Otherwise it would have been difficult.
Yes.
So here I have marked here. Give me another glove. 7.5. So I'll be going about 10 centimeter lateral to midline.
Okay.
So I've taken AP and lateral shots.
Hmm.
So our target point here is center of the disc, not the posterior part of the disc.
Exactly, yes.
So because our target is the center of the disc, we need to clear the disc and put the cage in the center of the disc in both AP and lateral views.
Yeah.
So it is very simple. So our entry point will be about 10 centimeter lateral to midline.
Yeah.
Whereas if it is just a discectomy, it would have gone
Yeah, more lateral.
about 12 to 14 centimeter depending
Yes, yes.
on the patient. So we will try with the 10 centimeter incision
Okay.
from the midline. Knife, blade. This is 4-5. So I just make a small stab incision.
Yeah.
If I am not happy, I can extend it medially or laterally depending on the situation. Sure? Sure.
Yeah.
It is going through.
Harsha, you don't have to compress the screws.
Sure.
Sorry?
Harsha, can you hear it? Okay.
Yeah, I can hear.
You don't need any compression here, I believe.
Sure.
Yeah, no, I can't use compression here. I can. There are some specific. You can use 2 screwdrivers and try to compress it. But point is, if you are using a polyaxial screw, it doesn't transmit into much of compression.
Okay. Yeah.
The cage will not come out. I guarantee that.
Yeah. So if you put a snuggly foot and it's anterior enough, it should not come out.
Yes.
It is snug fitting, so it won't come out. So I have to go a little more proximal.
Lineback.
So let me check.
Sure. Mahisha, can we see the image from your side?
They will show you in a moment.
I think Harsha has finished his job, so.
Sure. Avrige image on torse. So what I am doing is I am hitting the facet first and then going in. Sure. So this is not acceptable.
Oh, okay.
So I have to go more caudal.
More vertical.
Sure. Okay, that is more acceptable.
Yes.
So now I am entering the disc. Sure. Okay. Show
Okay.
AP.
Yeah.
So always check both views. So I should be at the medial pedicle line somewhere. So let us see. So even if the screws are there, it doesn't affect you about the putting your, so it is fine. Can you see lateral again? 1 second. So I'll push it inside till the middle. Sure. Okay, lateral. So I pushed the needle to the center of the disc. So that is my target point.
Okay, good.
So I should be in the center of the disc in lateral view. Otherwise, I have to adjust this now, because later it becomes very difficult to change. So I am quite happy with this. Are you? Can you see the lateral view? Hello?
Hello, yeah.
Don't shoot unless I tell you, okay?
Yeah, it's almost reached the center now in the lateral view.
Yeah.
So in the AP view also it should be in the center?
Yes.
Okay.
Both views it should be in the center of the disc.
Right.
So it is in the center of the disc in both views now.
Okay.
So I will put the guide wire and then dilator.
Yeah.
So I am not putting any special cannula, I am putting the normal cannula, nothing
Okay.
special.
Okay.
Dilator. So this dilator is 7 mm and cannula is 8 mm. Sure? Sure. So if the guide wire moves, just push it, pull it outside. So always graze the facet so that the root does not come in the way. Sure? So I can feel the facet when I go.
Artery.
Okay?
Yeah. Yes.
Sure?
So you're on the annulus now.
Yeah, I am on the annulus now. So I'll take out the guide wire, hammer this inside. Sure? So I'm just going inside.
So you try to go to in the center of the disc or towards our superior end plate so that we have space.
Center of the disc, sure.
Okay.
Okay. So I'll go some more.
Sure.
So now I'll take it.
Mahisha, this patient under GA or epidural?
Patient is under GA. So that's why I have to be very careful.
Uh,
Always hit the facet so that
Hello?
Hello?
Yeah, yes, Mahisha.
Yeah, can you hear me? There was
Yes,
a
yes.
communication failure.
Yes, yes.
So you can see that in the AP view,
Yeah.
my dilator has
Cross the midline.
crossed the midline and it reached the medial pedicle line on the other side.
Yes, yes.
So that means my position is perfect.
Okay.
Okay. Now I am putting the cannula inside. This
So if you
patient
see a
is,
lateral, we'll
patient is under GA. Okay, sure.
Yeah. Okay. Thank
So
you.
that's why you have to be very, very careful when you put the initial guide wire.
So if
Sure.
you take a lateral, then it will be in the anterior border, is it?
Yeah.
Yeah.
We show the lateral. They will show you the lateral, previous lateral. Show the lateral. There.
Yeah. Okay.
Ulta. Okay. Take one AP now.
Yes. Yeah. We can make out.
Take one AP now. Yeah. Sure. Okay. Put one lateral now. Lateral. So we will do some manual discectomy with the curate, just like we
Yeah.
did earlier.
Okay.
Okay. Steps remain the same.
Yeah.
Okay, sure. But here it is much faster.
Okay.
Sure. Okay.
Yes.
So I put this curate now. Sure. So sure. So I am curating the lower end plate now.
It is a straight curate or it is a flexible?
It is a curved curate.
Curved curate. Okay.
Section.
But you're not doing it through the scope, is it?
It is
It's
going
cannula.
through the cannula only.
Cannula
sure.
only, yeah. Okay.
So I just go between the end plate and the disc and curate the disc. So this you have to be very careful, because if your position is not proper, it can come out on the other side in the AP view.
Okay.
So always you should take AP and lateral views. Once it had happened, I was overzealous and pushed it and punctured the annulus on the other side.
Okay.
Okay, so you have to be careful. But other side nothing is there unless you cross the anterior part. Sure. Of course, there are vital structures. I am not saying nothing is there. So now I will go for the upper end plate. Sure. So go between the end plate and the disc, or the bone and the end plate, whatever. Sure. So when there is doubt, always check both AP and lateral views. Don't do it under one view.
The mic off.
Sure.
No, this is straight. Straight. Yeah, the thing is remove the scope. He's doing it only through the cannula. So you can put a bigger instrument, which is straight, you can manipulate inside. If it is the scope, then you don't have much of play inside. So that cases we use the flexible ones.
So now I am using a grasper.
Flexible ones
to remove
takes
the disc.
a lot of time and the job
Hello,
is
if I'm still audible?
Yeah, yes, Harsha.
Yeah, we are done and we are closing. We have got a very good thing. So
Yeah, thank you so much.
Yeah.
It was nice to watch.
Sure.
Yeah.
So now I will use my expandable reamer to clear some disc. Okay. So this again goes in shoot. Okay. So now I open it. Sure. Sure.
It is the same instrument you used in the previous case?
Yeah. I'll reduce it.
Yes.
Sure. So I can adjust the size. So depending on this space is not very big like the previous case.
Mahisha?
Yeah.
This curate what you are using, it is a part of the set what the company gives or you have to buy it?
I don't know whether, I don't think it is there in the set. Sure.
So you bought it from the company?
Yeah, if you want, he will give it to you. You have to ask for this expandable curates. Okay. Sure. You see, it will curate both ends. Sure. 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 So once you do that, you can take it out, give a grasper. Sure. So with this, you can effectively clear the disc. Okay, clean. Because the work with the endoscope becomes less. Sure. Clean. You see the disc. Clean. Here the space is not very big like the earlier case because this patient had a previous surgery. So we may be putting a 10 mm cage here, not more than that. Curate, curate. ये दे दो. Sure. Sure. Clean. We have another expandable reamer which is not there with me right now. Show. Which will give the size also. Can you hear the grating sound?
Yeah, yes.
Hello?
Yeah, yes, yeah, Mahisha, we are watching.
No, can you hear the sound?
Ah, yeah.
The grating sound
Yes.
of the end plate.
Yep.
See the disc? Of course, some people do not use the endoscope. Just put the graft and finish the work here, which is not ideal. The final preparation has to be gauze piece has to be under endoscope. Gauze kodappa.
Mahisha, which company instruments? Jayon?
The instruments are from Hebbar Surgicals.
Hebbar, okay.
Yeah.
I mean, even that curate and all those.
Yeah, all are.
All from.
All are.
Hebbar, Hebsons.
I am a strong proponent of Make in India.
Yeah, I know.
We started this even before Make in India was popularized.
Yeah, you gave the idea to Modi, in fact.
एक बार curate, अलग curate. This one. So we are not using many instruments. We are using very few simple instruments. Nothing special. Sure. Clean. Don't touch this. I don't want to touch this. Okay. Sure. So nothing is left now. I will put the endoscope, put AP. So irrigation. Can you get the irrigation? Yeah. CM पीछे हटाओ थोड़ा. CM इंदे ಕೊಂಡೋಗಿ. AP ಬೇಡ ಅಂದ್ರಲ್ಲ ತೆಗೀರಿ. ಲೈಟ್ ಆನ್ ಮಾಡಿ.
Yes, remote the
ಲೈಟ್ ಆನ್ ಮಾಡಿ. ಸಲೈನ್ ಆನ್ ಮಾಡಿ. ಯಾ. ಲೈಟ್ ಆನ್ ಮಾಡಿ. ಇಲ್ಲಿ ಒಂದು ಇದು ಕೊಡಿ ಬಕೆಟ್.
No, he will removing it with the grasper. The tissue whatever is removed from there.
Top light off ಮಾಡಿ.
No wash, I think.
No, not required. That is only for.
Mahisha?
Yeah.
Are you planning to give some wash there because irrigation is already working there?
Where?
Now, you plan to wash those end plates, something, give a wash?
Yeah, I will clean the end plate just like we saw the end plate in the first case. Okay? The steps are same. Okay. Steps are the same, nothing changes.
Yeah.
Only the route is different. Okay. Grasper. Clean. Because we have curated, there will be some bleeding. It will clear in a moment. Clean. And also there will be some disc material. That's why you should always put the endoscope. The preparation is incomplete unless you see it. Curate. Can you see there is so much material?
Yes.
Inside. Though we thought it is enough. It is not enough. Okay. Grasper. So there are no shortcuts.
Yeah.
If somebody says I finish in 20 minutes, it means that he is doing half job.
There is no hurry in completing anything.
You see, so much disc material is inside. Okay? You are able to see the endoscopy?
Yes.
So there is so much disc material inside which has to be removed.
Yeah.
If somebody says it is not required, he should put one endoscope after he prepares.
Yeah.
Because when there is so much tissue inside, the fusion may not take properly. And also other thing is, the space here is narrow. So we cut this annulus and make our window bigger, cutter, so that there is enough space for the cage to go. Otherwise the space is very less here. ಬೇರೆ ಕಟ್ಟರ್ ಕೊಡಪ್ಪ ಕ್ಲೀನ್ ಮಾಡಿದ್ದು. So I am cutting the annulus now. So this way I medialize my cage. I remove the medial part of the annulus so that the cage will be more medial.
You have any plans of seeing the epidural space and again going back anything, or
no, I am not
enough?
Planning to see the of course we will see a little bit of epidural space also.
Okay.
But not too much. I will not be exposing the dura. See, I come out now.
Yeah.
Okay.
No,
so this is the epidural space.
Yes.
So what I do is I cut this annulus.
Yeah.
So my window, annular window, it becomes more medial.
Okay.
So this is the space I create for the cage to go.
Yeah.
So if you don't do this, your cage will impinge the exiting route and cause problems. Cutter, big other cutter. Okay. Yeah. You see, this is the tough tissue of annulus. So unless you clear this,
yes,
your cage is going to hit the.
Yeah, because you cannot medialize it further, so that's why you can damage the exiting route.
So there is a purpose. So
exactly.
It is not madness. There is a purpose why you put the scope. So this is not possible without putting the scope.
Yeah.
So we need to medialize. You see that tissue.
This is anterior, sir. So this is posterior.
Medial to the annular entry is removed. So our annulotomy has gone medial now.
Yeah.
So this is creating space for the cage. So this will avoid post-operative complications like dysesthesia.
You can use a RF to just burn it. I mean,
yeah.
Help.
No, I have to cut it and then burn RF. Okay. So now I will burn. So we have this excellent Bond probe.
Yes.
So
it's very good. I'm happy with that. I'm using it.
You are a rich man.
No, I'm not.
I am a poor man. So I can afford it only in conferences. Cutter.
Come on.
Jokes apart, it is a very good RF.
Yes. Especially for these type of cases and stenosis, it sort of lessens your job to a large extent.
Yeah, can you see the epidural space?
Disc will not be required, but too much.
Bere cutter kodappa. It's not cutting. Can you see the epidural space?
Yeah.
The
you can see the
there.
flapping. Yes.
Okay.
Yeah.
So this is the epidural space here. So if you can appreciate, before I put the scope, where was our annular window and where is it now?
Yeah.
So I am creating enough space for the cage to go.
Okay.
So finally, if you see, our cage will be going somewhere close to the place where we have done interlaminar surgery.
Yeah.
So this medializing annulotomy is very, very, very important.
Okay.
Otherwise, you will have post-operative problems.
Okay.
So when we started this transcam infusion, we had problems
Okay.
of post-operative dysesthesia because we are not doing this.
Yeah.
So once we do this, dysesthesia is very less.
Yeah, the initial assessment was that when this was started through
RF.
transforaminal,
Yeah.
just to be more anterior so that you can put the cage in a safe place without
Yeah.
disturbing the structures, and
ಇದು
because of
movement
that,
ಆಗೋದಿಲ್ಲಪ್ಪ.
the exiting route problem started.
ಮೂಮೆಂಟ್ ಆಗೋದಿಲ್ಲ ಇದು, ಹೋಗಿದೆ ಇದು, ಮೂವ್ ಆಗೋದಿಲ್ಲ. Somehow this movement is not working. I'm unable to move. This is a straight probe, unfortunately. Okay, can you see now? So I have done a medialising annulotomy cutter. I will remove some more
She has very minimal
tissue from here.
Mainly back pain, no
Okay.
radicular pain.
So this is the foramen area.
No radicular pain.
So there is a osteophyte here.
Just stabilize it.
So you can see I have made at least 5 millimeter of space for the cage to go. Now can you see the exiting route at 3 o'clock position? So this is the foraminoplasty for that. So this is the osteophyte which I am removing now. Grasper. Can you see the exiting route? Dr. Ravindra.
Sir, at what? At 3 o'clock, sir?
Yeah. At 1 o'clock, sorry.
Sorry, no.
1 to 3 o'clock you see the exiting route.
Yeah.
RF. Can you see?
Yes,
Grasper?
yes.
So we are doing a very good
This side,
decompression here
Left side, yeah.
before we do anything. RF.
ಇಲ್ಲಿ ಕಡೆ ಸರ್ 3 o'clock ಬರುತ್ತೆ ನಿಮಗೆ.
This probe, it is not
Arsha,
bending.
Mahesh, can you just orient us a little? The exiting route is towards 3 or 9?
3 o'clock. See here.
Okay.
The probe, no, it is not.
No, it is not. You can angulate it actually.
The cutter,
but I think
yeah, but it is not.
It is not. It's
See,
not.
this is the exiting route. Can you see?
Yeah. Yes.
Okay, cutter. If this probe was able to angulate and bend, I could have burned that tissue and shown you. But unfortunately, it is not working. I will anyway cut this tissue. Okay, this is the fat over the exiting route.
Yeah.
So I will not remove too much tissue so that some tissue is there for protection. Can you see the pulsation?
Yeah, if it's possible, can you show us exiting route just to see at least the pulsations or maybe the flapping? That should be enough.
So I am working very close to the exiting route here. Dissector kodappa. So you can see the my osteotomy, annulotomy which has gone so much medial. You see the exiting route is here.
Yeah.
Okay. Unfortunately, our RF is not working properly, so I cannot burn this tissue here. So this is the route here. Can you see? That is the route. Okay.
Sir, can you again go and show the route, sir?
Yeah, this is the route. See, my dissector is on the route. Okay.
Okay.
This is the route. I will
Yeah,
retain some tissue here so that it is going to protect the root. I will not take out all the tissues. Okay?
Yeah.
So I will use the dissector to create curate.
I mean, we know that where the location is. That's good enough.
We need some tissue for protection. We don't want the root to be bare there.
Yeah.
So what I have done is I have created lot of space medially for the cage to go.
You find it more difficult to remove all this disc through transforaminal?
No.
compared to interlaminar?
No, no. Transforaminal will be faster and more comfortable.
Okay.
So, you see now, your end plates prepared, accurate. So, Gore sir will be happy.
Yeah.
If he is watching. Okay. So, transforaminal is very easy, very fast, very effective. Grasper, brother, grasper. Clean. You can see that we have prepared the end plate fairly well.
Yeah.
Only little bit clearance is remaining.
Exactly. Once you
Okay?
take it out,
Correct?
then we can visualize better.
Yeah. And you can see that my instrument has not damaged the end plate.
Yeah.
Okay?
Yes.
That's also very important.
Yes.
I have not eaten away the bone. Only this final clearance is remaining. And transforaminal approach is very, very kind to your shoulder.
Yeah, of course.
Unlike
the best position to
interlaminar
work.
approach. Cut.
Yeah, yeah.
There are advantages and disadvantages. So we are showing you both.
Yeah, finally that's what, I mean, whichever you're comfortable with.
Yeah. Whatever is comfortable and whatever is beneficial for the patient, you have to do. At the
Exactly.
end of the day, patient should be benefited.
Yeah.
This probe, no, I am very unhappy.
No, that actually it's not working in the sense that it's working,
because
but you
straight
cannot.
probe will not be of any
you
use
cannot
for
bend
us.
it.
Yeah,
I think
grasper.
that leverage
So
is
sometimes what you can see now, I am using the cannula as a dissector, grasper.
Yeah.
To remove the bone. I am in end plate.
There must be another. They have given one more.
Anyway,
probe. You can use it.
Doesn't matter.
And there's a new one I think which they have given. You can use it
we
also.
can finish the work now. Tagoppa.
After some time it stops working.
Yeah, curate. So now I have finished the lower end plate. I will go to the upper end plate. Okay.
Yeah.
This is the upper end plate.
Any use of a motorized shaver in future?
Yeah, I think it will come. Currently we are doing some grasper.
Yeah, I know you must already be planning.
Grasper.
Make in India.
Earlier we used to take 1.5 hour for disc space preparation, but we don't take so much time nowadays. Curate. So I am putting a 10 mm cage here.
Okay.
Which is good enough. Up to 10 mm you can very safely put grasper without issues, grasper. Beyond 10 mm you have to think in transforaminal.
Why is that?
The exiting route may be stretched.
Okay.
So that is the only issue. So already you can see the dural pulsations at the top.
Yeah.
Okay. So it means I have to go more vertical now, a little more. So I use again this. You can use the cannula.
Yes.
As a dissector. Grasper. Take puff. Take. Clean. Ready, huh? Curate. 1 second. Transfer. Curate. Sorry. G-bone banta. Grasper. Clean. Curate. Grasper. Curate. You have a RF working now? Huh? ಏನು ಅದಲ್ಲ ಅದು ಬೆಂಡ್ ಆಗೋದಿಲ್ಲಪ್ಪ ವರ್ಕಿಂಗ್ ಕೊಡಿ RF ಕೊಡಿ so let us see we have a working direct who is stopping it ನಿಲ್ಲಿಸಿ ಅದು ಸ್ಟಾಪ್ ಮಾಡಿ so I think I prepared the end plate. Can you see? Hello?
Yes, sir. Yes, you, we can see.
Yeah, we have prepared the end plate. So
yes, sir.
We'll put graft and the cage now.
Okay, sir.
The route is here somewhere.
Yes, sir.
It is free.
At 3 o'clock.
Okay, it is safe. So I will take out the scope now. Okay. I'll put the G-bone and give me a knife and some. So if somebody can focus here, where is the, see the amount of disc we have removed? Can you see?
Yeah, yes.
Okay.
So now you're going to put it over a guide wire, the cage?
Yeah, we are going to put over the guide wire.
Okay.
One thing I wanted to show you here, just a minute. So, light on idella. So before I forget, so you can see the bevel of my cannula. Okay.
Yeah, yes, yeah.
So bevel of my cannula, it is adjusted so that it is symmetrical on both end plates. Can you see?
Yes.
And you see the angle here. Okay.
Yeah.
So this is my lordosis. So otherwise your scope will, cage will be going rotated.
No, come again. Explain that point again.
See my cannula.
Yeah.
It is not horizontal like this.
Okay.
It is tilted by about 15 degrees.
Fine. Yeah.
So this is the lordosis you have to give.
Okay.
With the cage.
Okay.
So I'll show you in the cage. I am putting a 10 mm cage here. It is to 8, 9, 10, 11, 12. So I am putting a 10 mm cage here. 10 alla nodapa. Yes. Huh? So this is a 10 mm cage. G-bone ready? Okay. Open ಮಾಡಿ ಚಿಕ್ಕ ಪೀಸ್ ಮಾಡಿ ಗೈಡ್ ವೈರ್ ಇದೆಯಾ ಗೈಡ್ ವೈರ್ ಓಕೆ ಸರಿ So the cage, you know, can you see here? The cage, if I put it like this, it will be in a rotated position. So I need to go like this with 15 degrees angle. This is to compensate for the lordosis. Cut mud. Okay?
Yeah.
Guide wire ಎಲ್ಲ ಬಿದ್ದೋಯ್ತಾ?
You'll use a thick guide wire for this?
Yeah, I used a big guide wire because we had a guide wire, but we gave it to Harsha that side. But anyway, we have some other guide wires.
No, I meant you use a thicker guide wire compared to what we use in transformer?
Yeah, it is a thicker guide wire.
Okay.
So we packed the graft with the guide wire inside.
Okay.
So that otherwise what happens is if you pack it normally you cannot put the guide wire.
Yes, yes.
So now I have packed here. The only problem with G-bone is it comes out. That is one issue. Thoda blood milega. Thoda, I will take some bone marrow. Okay. Give me a knife. So give me a small knife. So this contains all the osteogenic material. So take a gem syringe on the 5 cc or 10 cc syringe kodapa. So you feel the crest.
Yeah.
And go inside, hammer. Orthopedic surgeon will not use CM for this, yes, but neurosurgeon will. Okay? Needle holder eno kodappa. So, needle holder kodappa. Because for orthopedician, bone is very close to your heart. Syringe kodappa. 5 or 10 cc syringe kodu. So bone marrow has to come here. Okay?
Okay.
Yes. So this is the advantage of being an orthopedic surgeon. So 5 cc of bone marrow is good enough for your graft. Okay? Brother, hakappa. Graft alla hakkolu. Okay. ಅದೆಲ್ಲ ಬಿದ್ದೋಯ್ತು ನೋಡಿ. ಅದಕ್ಕೆ ಸ್ವಲ್ಪ ಇದಾಗ್ತದೆ, ಇಲ್ಲ ಬಿದ್ದೋಗುತ್ತೆ. So it will hold the graft together, the bone marrow. Okay. So now it will not fall down. Okay.
Yeah. Okay.
So you can see that the cage is packed. Okay.
Yes.
Now it is not going to fall down. So there is bone marrow.
Okay.
Okay. And always see that it is very, very tight.
Now, Mahisha, now you have the cannula placed there.
Yeah.
So you have put the guide wire already into the cage.
Huh.
So how is it now? I mean.
Again, what I have to do is I will first pack the graft here, then we will come back. Okay. Can you get the C-arm lateral? Yes. Yeah. C-arm lateral. So come. Graft punch. Lateral akka. So we are doing it under lateral view. Take it out. Don't touch that. Table up idea.
Your CM technician was all over the place yesterday in banquet dinner, so, but he's quite active today.
Yeah.
ಅವನು ಕೆಳಗಡೆ ಮೇಲೆ ಎಲ್ಲ ಕಡೆ ಇದ್ದ ಅವನು.
To my surprise, they are quite active and alive.
Yeah, that's what.
I thought they will be dead.
He was doing some snake dance and all yesterday.
Yeah. Maybe you should have put that also in your YouTube. Huh? Shoot. So my cannula is inside. I am putting this. Okay, increase the factor. Okay, so there is so much of graft there, so it goes inside now. Sure. So because we are using a normal cannula, there is no stretch on the root.
Yeah,
Sure.
exactly. Yes.
Dr. Syed Usman uses a big cannula.
Okay.
So that we have found that there is more stretching of the root.
Yeah, maybe the Americans are bigger.
Yeah. Sure. Okay.
Yes.
Kodappa. Cage. So whatever we have put about 10 cc of this G-bone.
Okay.
And next the cage will go. Normally back home I use allograft, but the G-bone also will work. We did one case in Ahmedabad about 4 months back.
Okay.
So there we did 4-5 interlaminar and 5S1 transforaminal under GA.
Yeah, you showed me those yesterday.
Yeah,
those
yeah.
case.
In
Yes,
follow
yes.
up, I showed you.
Yeah.
It is excellent. Sure. Okay, you can see the graft anteriorly.
Yes, yes.
So that is good enough. Okay, now we take out. Now I put the guide wire. Keep it. So I use this blunt part to go inside. Sure. Okay, the guide wire is inside. I'll just push it some more so that it doesn't come out. Sure.
So you are anchoring the guide wire in the graft.
Yeah. And now I take out this cannula. This is troublesome.
Now here I wanted to ask is,
Give me
once
a
you
knife.
remove the cannula,
Huh.
now the guide wire is free by itself.
Yeah.
So any chances of a bit of a migration of the cage?
Migration of cage.
Yeah, I mean to say it may be not be the exact place where you intend it to go.
No, it will go exactly where the guide wire is.
Okay. And any bending of the guide wire you noticed any time?
No, never. Because this is a thick guide wire. It is not a normal guide wire we use for transformal surgery. It is the same guide wire which you use for this percutaneous screws. Okay, now the guide wire is out. So if you see the cage, it has a smooth part anteriorly and a serrated part posteriorly.
Okay.
So now I remove this guide wire. Okay. Now I go here.
That is because of the shape of the cage that it slowly avoids any damage to the durable structures.
Yes, absolutely. Cage has the magic.
Shape, so
okay.
It is totally blunt like what because that bullet allows it to.
So give me a marker pen. So I will just mark my position so that I have to give some lordosis to the cage. Okay. There's some skin that, okay, now it went in. Sure. Okay.
Yeah.
So now the critical part.
Yeah, going down the
Sure.
facet. Yeah.
So going slowly.
Any neuro monitoring?
You can do neuromonitoring, but we don't have. Sure. Hammer. So far, neuromonitoring not required. Sure. So now it is entering, you see.
Yeah. Anytime you face
Sure.
difficulty with a broad facet,
With the
broader facets,
which passage?
facet broad. If the facet is very
no,
broad.
no. If there is problem, I would have buried it.
Okay.
Sure. Okay. Now
Yeah.
we are just entering.
Yes.
Now I take out the guide wire.
Okay.
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 So now I go in. Sure. So now it is entering.
Yes.
Sure. So that you see,
Yeah.
the root is stretched only for a fraction of a second.
Yes. Yes.
I don't spend time with the cage stretching the root.
Okay.
Now root is free.
Yeah.
Okay, now we check AP. Sure. So we have enough space in the lateral view to go. We check AP. And you see the cage position is perfect.
Yes. Yes.
Size is perfect.
Yeah.
We just have to put it inside, that's all. And you see the graft anteriorly.
Yes, yes, perfect.
Okay?
Yeah.
Sure. And if you compare the interlaminar size, this is much faster.
Yes, definitely.
Okay? See, my initial position was perfect.
Yeah.
So that's why I have enough space to push the cage now.
Okay.
Okay,
Okay.
I'll go some more here.
Fine.
Sure. Okay, now we take a lateral.
Sure. Now you find that the cage placement here is more horizontal compared to what you do with interlaminar?
And these are two different directions.
Yeah.
Because the approaches are different.
No, I'm trying to get some support for transforaminal.
Yeah, this is a beautiful procedure. Sure. We'll see in the lateral view where it is. Okay? Are you happy?
Yeah, yes, perfect, perfect. Mahesh.
You see now?
Yeah.
You see here? Focus here?
Yes.
Okay?
Yes, yes, fantastic.
Do you want more compression?
No, that's enough, that's enough.
You see the whole table is moving.
Yeah.
Okay?
Yeah.
So this is, if your size is perfect, it will be like this.
Yeah, fine.
Okay?
Okay.
Now we put the guide wire. I will show you the route again, because we have put a blind cage.
What will be the cost of the cage and the 4 screws, total package?
Screws and the cage will come to about 35,000, less than that.
Altogether?
Dilator, yeah.
Including the G-bone?
G-bone is cheaper, no? So it will be 35. If you use allograft, it will come to 40,000.
Okay.
Oops. The block agideppa. The innond guide varaka. So is there anybody to watch apart from you?
Sorry?
Is there anybody in the hall apart from you?
No, many people are here.
Okay. So we'll put the. Can you get
what
some
questions I'm asking are coming
steroid?
from them.
Okay.
Yeah.
Can you get some steroid for me? Steroid. So we always put some steroid to avoid post-operative dysesthesia. Sure. Okay.
Yeah.
My dilator is going inside. Sure. Sure.
So you just want to visualize the base of the cage.
Needle holder. Are you happy with the position of the cage in lateral view?
Yes, yes, yes.
Okay. Dilator. So the secret is the initial guide wire. So if your initial guide wire is perfect, this also will be perfect. So now I put the cannula, take out the CM. So now the cannula is inside, there is no business for CM, CM can go out, and we just see the final look and then come out. Of course this will take some time, so but you should do all these steps properly. So I am putting the scope again, there will be some bleeding, grasper. We will see the cage, we will see the exiting route, see that there is everything is all right there, and then come out. So I hope I can catch my bus.
Yeah, you can. Can we see the scopy picture?
Yeah, 1 second. They will show you. Some fogging has happened, or
Your bus at 4 o'clock.
there is some fogging here. Cut madida. I think some fogging has happened. Just cut made. There's some fogging happened in between because it was hot. So take the body, clean ಮಾಡಿ. ಇದು cut ಮಾಡಪ್ಪ brother. Cut ಮಾಡಿ. Give me a minute. Okay, ಅದು clean ಮಾಡ್ಕೊಪ್ಪ. Okay, clean ಮಾಡಿ. Okay, fine. Can you see the cage?
Yeah, yes, yes. Beautiful.
Okay. So the cage is there. Can you give me a RF? So, oh, this is a continuous RF. Okay. So the route is free here.
Yeah.
Okay. 1 second, I will show you. Grasper kodappa. Off. Grasp.
There's a problem with one of the RFs which you have stopped using. It fires continuously.
Cutter, kodappa. I'll just show you the exiting route and then come out. ಬೇರೆ ಕಟ್ಟರ್ ಕೊಡಪ್ಪ. ಹಾಂ ಕೊಡು. ಎರಡೂ ಹೋಯ್ತಾ? ಓಕೆ, ಗ್ರಾಸ್ಪರ್ ಕೊಡಪ್ಪ. Can you see the exiting route? At 3 o'clock position.
3 o'clock, okay.
Okay. Just clean some.
You can just flap it so that we can appreciate it.
1 second. Just give me a minute. I'll clean some blood clots here. If we have a good RF, we can show it very clearly. Can you see this reddish tissue?
Yeah.
That is the exiting route. The cage is here, sitting well.
You say around 1-2 o'clock area?
Yeah, this is the exiting route. Cutter.
Yes.
That is the exiting route.
Sure. Okay.
There's some annular tissue is here. Down, Madi. Full. Cutter. Can you see the root there? So just a minute. Let's clear some tissue here. Okay, head cover. So I just come out. Yeah, this is the,
that is the root.
Okay,
Yeah,
there is the root.
Yes.
So we have not caused any damage to the root. It is quite free.
Okay.
Okay, cutter. Steroid manta. ಒಂದು ಕೊಡಪ್ಪ, ನೀಡ್ಲಲ್ಲಿ ಕೊಡು, ಲಾಂಗ್ ನೀಡ್ಲಲ್ಲಿ. ಎಲ್ಲಿ ನೀಡ್ಲಿ?
But you're okay with introducing some foreign, using a depometrol there when everything is open?
This is the only time I use steroids, and also sometimes if I do a foraminal disc, I will do steroids. Can you see the cage sitting against the end plate?
Yeah.
Can you see here?
Yeah.
See that flat of the cage is exactly parallel to the end plate.
Yes. Yeah, sure.
So this is what I was talking about, the lordosis. Can you see?
Yeah.
There is no rotation of the cage.
Oh, yes.
Okay?
Yeah.
So every step has a value. You see the lower end plate?
Yeah.
See, it is
fitting,
exactly parallel to the end plate, and you see the bone inside the cage.
Yeah.
So bone has not fallen outside.
Okay.
So everything is good.
Fine.
Okay?
Okay,
the exiting route is here.
Yes.
It is free.
Yeah.
Okay?
Yes, we appreciate, yes.
So I'll take out the scope.
Yeah.
And we will put some steroid and call it a day.
Okay, thank you so much.
Yeah.
Because a big applause.
So thank you for waiting to see this.
Yes, thank you so much.
And I will come down shortly.
Yeah, sure.
Ready, yeah? ಕೊಡಪ್ಪ. ಎಷ್ಟಾಯ್ತು? ಇನ್ಸ್ಟ್ರೂಮೆಂಟ್ ನಂದು ಒಂದು ರಪ್ಪ ವಾಶ್ ಮಾಡಿ ಕೊಡಬೇಕು. ಡೆಪೋಮೆಟ್ರೋಲ್. ಐ ಡೋಂಟ್ ನೋ. ಟ್ರೈಕಾಟ್ ಮೇ ಬಿ, ಐ ಡೋಂಟ್ ನೋ. ಸಿಸ್ಟರ್, ಅಲ್ಲಿಂದ ನಂದು ಮೊನೋಪೋಲರ್ ಕೇಬಲ್ ಮತ್ತು ಇದು ಪ್ರೋಬ್ ಮತ್ತು ಕೇಬಲ್. ಹೈಡ್ರೋಕಾರ್ಟಿಸನ್ ಅಲ್ಲ, ನನಗೆ ಟ್ರೈಕಾಟ್, ಕೆನಕಾಟ್ ಯಾವುದಿದೆಯಾ? ಹೇಗಿದೆ? Came out very well. Even this case, very well. ಚೆನ್ನಾಗಿ ಬಂತು. You have demonstrated everything. How it is done, why it is done. You just don't do just for namesake.
It is easier than interlemma.
Yeah, it is much easier. Yes, sir. See, I am very open to the techniques. I do both, and I will tell what are the drawbacks in this, what are the drawbacks.